Assalamu alaikum wa rahmatullahi wa barakatuh. This is the second day of our seventh internal medicine webinar from Saudi German Hospital, Riyadh. I am happy to announce for the beginning of the second day. Today, we have two sessions, nephrology and pulmonology. I would like to share with you how we will work today. As far as you know, we have 3 days with 6 sessions, 2 sessions every day, covering gastroenterology, hepatology, nephrology, pulmonology, endocrine, hematology, and infectious diseases. And each presentation will be around 20 to 25 minutes, and we'll have 5 minutes or 10 minutes for questions and answers. Also, you can send your questions in the platform for Q&A, or you wait till the end of the presentation, and by the end of the day, you will receive evaluation form. Also, CME hours will be accredited by the end of the 3 days for those who make the full registration and after payment of the fees. Also, for any inquiries, please contact our organizer, Mr. Tamer Ahmed, and this is his phone number for WhatsApp communication and phone calls. Thanks for everyone who attended today, and I will stop sharing now, and I give the floor to Dr. Gonzalez Suarez from Mayo Clinic. Dr. Gonzalez Suarez is a board-certified nephrology at Mayo Clinic in Rochester, Minnesota. She also has a doctorate degree in the field of immunology with a special focus in hypertension and women's kidney health, chronic kidney disease. She's a member in International Society of Nephrology and the American Society of Nephrology, and the director of Chronic Kidney Disease Clinic at Mayo Clinic. She has many publications in the field of nephrology, and today she chose to tell us about acute kidney injury in congestive heart failure. Thanks for joining us, Prof. Gonzalez Suarez. Am I saying your name in the right way?
Yes, that's
okay.
correct.
Thank you. Thank you. You may start now.
Yes. Hi. Good afternoon for you. It's morning time for us. Thank you so much for your kind invitation to participate. Today, we're going to be discussing acute kidney injury and heart failure, specifically focusing on the management of diuretic resistance. This is a topic that is very vast, and we're going to try to comprise it in 20 to 25 minutes. I'll do my best. I have no disclosures for this presentation. We're going to be reviewing the management of AKI in congestive heart failure, especially in those patients that have diuretic resistance. This is the outline for today. And let's start just with a quick clinical scenario. And this is just to comprise the vast majority of the patients that we encounter with similar symptoms. So this is a 70-year-old lady with type 2 diabetes, hypertension. She's admitted with shortness of breath. Physical exam, blood pressure is borderline low, mildly hypotensive. She's having increased respiratory demand, and the oxygen saturation is around 85%. On auscultation, you hear rales. And there is also, you notice lower extremity edema bilaterally. In the labs, her baseline creatinine is usually around 1.5, but it has increased to 2.6. The BUN is also higher, and the proBNP is around 5,000. On the chest X-ray, there's pulmonary congestion. The echo, this is a new finding in which we notice that she has decreased ejection fraction of 28%. Which leads to concerns of acute exacerbation of heart failure. She didn't have any history of heart failure before. So first, we're going to focus on the main part of our topic, which is this acute kidney injury that is presented in many of our patients. So how often it is that we're going to find acute kidney injury in cardiovascular disease? Let's just talk first about kidney injury in general for those patients that are hospitalized. If you go into the literature in search, you're going to find that according to different hospitals, they will be able to find different incidents of acute kidney injury. It can go from 10% up to 40% in some other cases. In average, it's somewhere around 15% of the hospital admissions. Of course, if we have predisposing factors, that will increase the risk of AKI. And from the AKI that we encounter in the hospital, the most common one is related to acute tubular injury, formerly known to acute or previously known as acute tubular necrosis. And the second most common cause is pre-renal. From the pre-renal category, as you know, we have many different causes of pre-renal AKI. Could be related to volume depletion, but today we're going to be focusing on the impaired renal perfusion, specifically associated to heart failure. This is an interesting recent publication in the SGH about a cohort of 21 hospitals in California. And they went retrospectively and checked how many patients they have admitted with AKI. And they compared that to patients that were admitted without AKI. And they were followed prospectively for a year. And they had around 31,000 patients with AKI, and they were matched against 115,000. So those are large numbers of patients. After they were followed for 1 year, they found that the risk of presenting heart failure after a year of having had AKI without any prior history of heart failure, it has a hazard ratio of 1.4, something that was not seen for other cardiac events, such as an acute coronary syndrome, peripheral artery disease, or even stroke, concluding that AKI is an independent risk factor for cardiovascular events. So as we know that there is this bidirectional correlation between the two organs, heart and kidney. And we know that patients that develop AKI and patients that have CKD will have higher risk of developing cardiovascular disease. As you know, CKD patients end up having a higher risk of mortality, and the number one cause of mortality is associated with cardiovascular events. So it's very common to see the association between the two organs. On the other hand, patients that have cardiovascular disease tend to develop acute kidney injuries as well. It is considered that around 25% will have an acute kidney injury event. And many of those patients will have heart failure associated with AKI. So going back to our clinical scenario, we do have concerns for an acute exacerbation of heart failure. And let's go and review the classification of cardiorenal syndrome to see which one our patient is be classified as. So the interlink between these two organs, it helps us maintain the water, saltwater homeostasis, and to maintain normal blood pressure as well. And there are 5 cardiorenal syndromes. Just quickly, we're gonna just review them. The first two, the type 1 and 2, are associated with a problem initiated in the heart that then leads to complications in the kidney function. And type 1 is acute, type 2 is chronic. On the other hand, type 3 and 4 are associated with a main focus on the kidney. So the kidney starts failing, and associated to that, it leads to complications on the heart. And it is also defined as acute or chronic, depending on for how long the problem has been started. So for our patients, we know that for that patient on a clinical scenario, we know that she did not have any prior history of heart failure, and that she presents with an acute kidney injury from a baseline that it was perhaps just a mild chronic kidney disease for her. But the fact that she presents with this acute exacerbation of heart failure leads us to think, and the most common type that we all usually see in these scenarios is type 1 of the cardiorenal syndrome. So for the majority of the patients that you will encounter in a hospital setting, the majority of them, they tend to be type 1, but there will be some others that have had kidney failure for many, many years, and they are already leading towards stage 4 or 5 of chronic kidney disease, and they start developing heart failure afterwards, or any other cardiovascular events, then those are the ones that are defined either type 3 or type 4, depending on where exactly we find them in the clinical scenario. We also have a type 5, and this have interrelation between the failure of both organs, and is usually a secondary cause that can cause the dysfunction of the heart and kidney. And this is usually related to something systemic, such as sepsis, trauma, shock, anaphylactic shock as well. So reviewing how the pathophysiology presents for this cardiorenal syndrome, and again, focusing more primarily on those cases where the heart is the first organ to be affected and then leading to kidney failure. There are 3 main components of the pathophysiology for cardiorenal syndrome that, if you go and look in the literature, are the main ones that are being presented. And these are, we usually start seeing hemodynamic changes that leads to neurohormonal activation, and along with others, signaling of inflammatory cytokines, all together combined will give us a presentation of cardiorenal syndrome. From the hemodynamics, we can see heart failure associated with left ventricular heart failure, usually with lower cardiac input and lower stroke volume, or when you see it or from the right heart failure, usually associated with increased venous congestions, both of them leading to decreased arterial filling. And this triggers other pathways of the hormone activation. There is an activation on the sympathetic nervous system and the RAS system, leading to developing or secretion of many hormones, including vasopressin, endothelin, and secretion of inflammatory cytokines. All these lead to water retention, vasoconstriction, and eventually leading to tubular damage and glomerular dysfunction. So this is the usual pathway on how we present or see the presentation of this clinical scenario for our patients. The symptoms from left heart failure, usually associated with respiratory failure. From the right heart ventricular failure, we usually see it associated with low blood pressure and edema. There are a lot of common symptoms associated with that, but they're non-specific, all of them related to cardiovascular disease in general, chest pain, palpitations, syncope. So those are, in general, very common for a lot of different etiologies of cardiovascular disease. But the one that we will focus on, because from the kidney perspective, will be the oliguria. And we start to see that these patients, something's going on in the system. They're not receiving enough blood flow into the kidneys because of that vasoconstriction. And this leads to kidneys that are not working well, and then they start developing oliguria. So we see a decrease in the urinary output. And this leads us to think, how are we going to be managing these patients that have failure in the kidneys, and they're not able to produce a larger amount of urine, and they are developing volume overload. We know that patients with volume overload have higher risk of mortality. So keeping a balance in the the input and output of these patients is important. So we're going to focus on what are the first line therapies that we have to offer to this patient. So we start with medical management, and we're trying to contrast all those events from the pathophysiology. So we know that there are hemodynamic derangements that lead to the kidney failure. So you were able to change the hemodynamics. Perhaps the kidneys will receive more blood flow, and by receiving more blood flow, then the kidney failure will revert. So we optimize hemodynamics with the use of inotropes. We can also help to restore the fluid balance. As I mentioned, volume overload is associated with higher mortality. So ideally, if we're able to find a balance in the volume overload by the use of diuretics, then hopefully we can prevent mortality. We'll see if this is true or not in the next few slides. And definitely avoiding nephrotoxins. So let's focus first on the diuretics, which is kind of our first line therapy. But knowing that in many cases, the use of these diuretics, because of the bad hemodynamics that the patient is presenting, it can lead to worsening of the kidney function. So that's why it is important to find a thin balance and trying to increase the blood flow to the kidneys and restore the fluid balance in systemically in order to find an improvement on the symptoms. So we know that patients that respond to diuretics seem to have better outcomes. This is usually on how they feel. They start feeling less short of breath. So the dyspnea is resolved. And once the dyspnea is resolved and the oxygen saturation is improving, those are the patients that we consider they are good to go to home with an oral diuretic therapy after we have given them several days of IV diuretics. However, diuretics per se have not been demonstrated to reduce mortality or to prevent the need of dialysis in those patients with acute kidney injury. So we use the diuretics mainly for symptom control. Unfortunately, we have not seen that it reduced mortality, although we know that patients with higher volume overload will tend to have higher mortality. Once we treat that volume overload, we have not seen a reverse on the risk of mortality. And that's something interesting and important to keep in mind. How to give the diuretics? Should we give it as a bolus or should we give it as a continuous infusion? There have been several clinical trials in this important topic, trying to figure out which one of the two is better. More recently, there has been this meta-analysis compiling the information of all these different clinical trials, and they have found that it really doesn't matter. You can give it through IV, you can give it continuously. If you give equivalent doses on versus bolus versus a continuous infusion, they usually end up having similar results. So you have a similar amount of diuresis. They are safe, both of the modalities, and there is really not much difference on clinical outcomes. The difference is that when the patient has very bad hemodynamics, they won't be able to tolerate boluses as much, and those are the patients that are preferred to be on a continuous infusion. But if you have a patient that is hemodynamically stable, giving one versus the others will be from the attending perspective preference, but not necessarily giving you a better outcome, having it as a continuous infusion versus a bolus as long as you give the same dose. Of course, being able to improve the hemodynamics is something very, very important. And there has been this a trial more than 10 years ago. It was called the DAD-HF trial. And we're going to start talking about a lot of different trials in this topic. They all have very catchy names for us to remember them. This one was about dopamine and see whether dopamine will help to improve that pathophysiology of hemodynamic rearrangements in order to improve the renal perfusion and heart failure. So there was a single center study in Greece in which 60 patients were initially treated with IV furosemide, and then they were randomized to give them either high dose of the loop diuretic versus a low dose of the loop diuretic plus dopamine. And they wanted to compare head-to-head comparisons, which one of the two will improve the diuresis, if there were going to be any changes in the creatinine. And they follow these patients for up to 2 months. They find that the volume was improved. The volume of urine was improved when they gave dopamine. So dopamine had a better effect on the hemodynamics and improved the renal perfusion in order for the kidneys to make a little bit more urine than just giving a high dose of the diuretic alone. The combination of the low dose furosemide with the low dose dopamine was as effective as giving just the furosemide alone, but the renal perfusion was improved, showing better renal function panels, so meaning that the creatinine was improved, the BUN was improved, and also the hyperkalemia was improved. With this in mind, it's important to focus on those patients that we are having in front of us with bad hemodynamics. We need to ask the cardiologist to help out by giving inotropes whenever it's possible in order to preserve the kidney perfusion, because we know that that will lead to better kidney function. But what happens with those patients that present diuretic resistance? You already tried everything, right? You gave them already the inotropes. You started with IV diuretics, either bolus or continuous infusion, but you don't see results. They're not making urine, or they're not making enough urine. What to do next? As a usual second line therapy, we usually add a second diuretic, also as an IV. And we're preferring and focusing on the IV presentation of the diuretics because we know that these patients, they have systemic congestion. And in many cases, trying to give a pill will not do the trick. So it will not help us to use pills in this scenario. So the tablets for the oral diuretics won't be helpful in many cases because they're not being able to be well absorbed. I remember the gut is also congested and there will be a decreased absorption. So that's why it is important to focus on IV presentation of diuretics. And we add a second diuretic, usually a thiazide. Historically, we used to use the management of saying, okay, so you give the thiazide 30 minutes before you give the loop diuretic in order to have a better effect and to have a better delivery of salt and water to the last part of the distal part of the nephron in order to improve the diuresis. Nowadays, they have done other studies that I'm not presenting because of time, but that show that you can give them all together. And you can give the thiazide along with the loop diuretic in order to improve the diuresis. Here in the United States, the IV thiazides are very expensive. And of course, we will use them if they're necessary for diuretic resistance. But in general, we will try to keep it for those patients that indeed, and it is clearly to have diuretic resistance and not for everybody. Many of the patients will be able to improve their condition just by giving IV loop diuretics. But what to do next? We already give the loop diuretics, we give the thiazide, and we still see this diuretic resistance. The patients are not making urine. So those are the patients that we start thinking, well, maybe they need dialysis, maybe they need ultrafiltration in order to preserve or improve the volume overload. So before we do that, we do this furosemide stress test. And this is routinely done in our patients that are specifically in the ICU, but of course we can use it also in the floor. And these are our patients that we don't know whether if they are responding to diuretics. The primary team is already asking us whether we should be considering dialysis or any sort of renal replacement therapy. And this stress test was first published as a study in 2013. Now it has become more of a day-to-day practice for us. And is to use a hefty dose of diuretics. It could be 1 to 1.5 milligrams per kilogram of IV furosemide. And we measure the urine output after 2 hours of giving the diuretic. And in general, a patient that will respond to diuretic will start making urine because it's a hefty dose, and we're expecting that to kind of help to see a urinary response. But if we see that in 2 hours, they have made less than 200 milliliters of urine, those are the patients that we know that more likely they will end up needing some sort of renal replacement therapy. So let's focus now on the renal replacement therapies that we have. We could use ultrafiltration as an intermittent dosages, and we'll go through the several clinical trials on it, or we could use continuous renal replacement therapy, the CRT in the form of CVVH, which is the most common one that we use here. But let's go first one by one. So the first one is ultrafiltration. So from our patient, the first line therapy did not show any response. So what are the next steps in management? And this is when we start thinking, okay, so what are we going to do about the renal replacement therapies? So the usual indications, and this is just as a reminder, we use the AIEOU indications. We're going to be focusing on the O, which is the volume overload, and from those indications, which is the one that fits our patient. One of the first clinical trials on the use of ultrafiltration was the rapid CHF trial, and this was 2005. This was a multi-center study in 6 hospitals in the Twin Cities, next door from where we are. And they wanted to see which one of the two was better, if we could use IV diuretics or versus ultrafiltration. Keep in mind that these patients are not necessarily diuretic resistant. They just wanted to see which one of the two was better. And as a nephrologist, you may encounter this very frequently, in which the cardiologists get a consult for nephrology, and what they want is to keep the volume overload as minimum as possible so they can focus on the symptoms of the patient, and they can improve more rapidly, and the length of the hospitalization can be shortened. So the faster that you're able to get rid of the fluid, the better for them. Unfortunately, sometimes the faster is not always the better route. And let's go through all these clinical trials that has been through time in this aspect. So this one was trying to assess the efficacy of using ultrafiltration versus the standard therapy that was the use of diuretics. So they used one single session of 8 hours. And keep in mind, 8 hours having a patient connected to a machine to do ultrafiltration versus giving IV diuretics. They were using this machine, is not the specific dialysis machine. It's a different type of machine that is less invasive, and that they're not requiring central access, so they can do that at peripheral access. And they were able to enroll 40 patients, which is not a large amount of patients, but it gave us sort of an aspect of whether if ultrafiltration was something to think about further or not. And they compare both of them. The endpoint wanted to see which one of the two will able to make more urine. So if we remove the excess fluid systemically by ultrafiltration, will the kidneys be able to make more urine? That's the question. And they see that after 48 hours, those patients that were just treated with ultrafiltration were able to make up to 8.4 liters of urine 2 days after, versus 5.3 when they were treated just with diuretics. There are certain caveats to this study, and one of them is that although the diuretics were held during the time that they were on ultrafiltration, they were able to receive diuretic afterwards. So when you compare apples to oranges, but the oranges is also having a little bit of apples. So it was not a clear cut. So meaning that the patients that received the ultrafiltration also received diuretics at some point versus just diuretic alone. And yes, of course, we're able to see a lot of urine output, but perhaps some of that urine output was coming not from the ultrafiltration, but from the diuretics. So we will know that unless we do a clear cut between the two arms of the study. And they were also trying to see, it was a very short period of time, 1-2 days after, to see how much urine were they making. Was this something that was going to be able to preserve over time? And if we were able to see it after several months after, we don't know. So yes, it's the first study. It has its value. but we needed more information. So the next trial that comes along is UNLOAD trial. Again, trying to see head-to-head comparison of ultrafiltration versus diuretics. In this one, on the treatment arm, they use exclusively ultrafiltration. IV diuretics were forbidden, which is a good start because we want to see if ultrafiltration on its own is better than IV diuretics. On the control arm, they use IV diuretics, and the goal was to keep it at least 2 times the usual dose that they were having as an oral dose before the hospitalization. And this head-to-head comparison shows that in average, the ultrafiltration group was having a fluid removal of 240 mLs per hour for 12 hours, meaning that these patients were connected to the machine also for a certain larger period of time versus the standard care. And the standard care, of course, the average of IV furosemide was given. Some of the patients, the majority of patients receive boluses, but some of them continues. And this is the important part of it. So yes, the patient with ultrafiltration without receiving diuretics had a significant better weight loss. The way that the patients were feeling was not that different. The shortness of breath was very similar in both groups. But this is where the red flags begins. The patients with ultrafiltration tend to have a little bit of higher creatinines, so perhaps worsening of the renal function than the standard care, which was with the IV diuretics. It was not statistically significant, but perhaps it was associated to the number of patients. It still gave us a kind of red flag from the nephrology world, thinking that ultrafiltration is not that great when compared to IV diuretics. For them, they conclude that although there were renal function changes, they were just moderate and similar because they did not reach statistically significance. And they felt, the authors, of course, being cardiologists, they felt that the ultrafiltration was better than diuretics alone. Then they came this trial, 2012, the CARIS heart failure trial. And this, again, trying to compare IV diuretics versus ultrafiltration. But now the IV diuretics are going to be used as a step therapy, meaning that they're going to be adjusting them along in order to keep a urine output between 3 to 10 liters per day versus ultrafiltration in average of 200 mLs per hour. They wanted to see if there were specifically changes in the kidney function to say which one of the 2 therapies was safer and which one of the 2 therapies we should be using as a first-line choice. It ended up debunking the other 2 studies in which they say, oh, maybe ultrafiltration is better. We see that if we're able to adjust diuretics along the way in order to keep a better urinary output, a higher urinary output, it may be better than ultrafiltration alone. We're able to preserve better renal function, and we may have similar results in the weight loss when compared for both patients' arms. Now, there is newer data, and this is from 2020, on the same study. So they went back and checked on those patients on the CARIS HF, and they wanted to see if they were to receive higher ultrafiltration versus lower ultrafiltration. So they went back and retrospectively checked those patients that have more than 200 milliliters per hour of ultrafiltration versus those that were having less ultrafiltration. They wanted to see if those with less ultrafiltration perhaps had less kidney damage. They saw that in general, both groups had similar BUN and creatinine. So for them, originally seen at it, there was not too much different to be aggressive with the diuresis, with the ultrafiltration versus less aggressive with the ultrafiltration. Indeed, those with a higher ultrafiltration had better urine output and better weight loss. However, when they look at the same data from a different perspective, combining with the ejection fraction, they see that those patients that have a higher ejection fraction, which is interesting, those that have preserve ejection fraction, that they have their hemodynamics are a little bit better. If we try to be aggressive about the ultrafiltration, we're able to see that those are the patients that develop worsening on the BUN and kidney function. So leading to conclude that patients with more preserved ejection fraction, they are more likely to have complications if we try to be aggressive about fluid removal. Leading to think, oh, perhaps those patients that have lower ejection fraction, lower than 40%, will benefit from being a little bit more aggressive, at least to be able to improve the symptoms, improve the kidney function, improve the renal perfusion by aggressive fluid removal. We don't know that yet, so that's something that needs to be investigated further. How about rehospitalizations? These patients with heart failure and acute kidney injury, they get hospitalized over and over and over again. And that's when we start to see a decline in their health and increased mortality, because we see them that they go just down the road very quickly and they get rehospitalized very quickly. What about if we try to improve their hemodynamics and improve their volume overload, and this decrease the risk of hospitalization? This was a small study, 56 patients. They were compared the same two modalities or two arms, which was the IV diuretics versus ultrafiltration. And the difference on this one is that the ultrafiltration, they were trying to keep it as 2 liters in the one session or several sessions, but try to remove 2 liters of the patient versus IV diuretics. And they see that the risk of rehospitalization with ultrafiltration is lower. So perhaps there is some potential benefit of ultrafiltration versus IV diuretics. But so far, we don't have a lot of data to prove that it is better. Again, the cardiologist loves it. From the data that we have nowadays, we still know that patients that receive ultrafiltration sooner, and they were able to improve first with IV diuretics. The IV diuretics have better benefits than ultrafiltration alone when it is not absolutely needed. This was one of the trials. This is from 2016. Unfortunately, it was not finished. They were trying to do this large study, multi-center, 810 patients. They were only able to enroll 224. The sponsor prematurely finished the study, so we don't have a lot of good data on it. They were looking at trend towards improvement with ultrafiltration instead of IV diuretics. But unfortunately, the study was not completed, and we still need more investigation about ultrafiltration. So far, we can tell that the first-line therapy for heart failure management of volume overload should be IV diuretics. There is some benefit for ultrafiltration. We will keep that as a second-line therapy, specifically for patients that have failed the IV diuretics, and not something to try it as a first-line choice. How about CRRT? Is it better? So let's focus again. What are the goals of the volume management? First, we want to use the IV diuretics, and we need to use that stepped diuretic regimen, meaning that we're going to try to focus on the urinary output and to improve the urinary output in order to decrease the symptoms. So this will improve the respiratory status, decrease the lower extremity edema, and of course will decrease the cascade of the neurohormonal pathway of the sympathetic adrenal cascade. But what are the next steps? So if we find diuretic resistant and there's still a volume overload, which one of the two is better to use? Should we use ultrafiltration with intermittent hemodialysis machine, or should we use a renal replacement therapy that is more continuous? Well, we know that those patients that in general we're going to need any of the two mortalities is because they're already in bad shape, and they already have a high risk of mortality and a higher risk of end up needing dialysis forever. So that's why we try to delay the use of these therapies as much as possible. But sometimes When there is really bad direct resistance, we don't have too much choice. We know that if we do it intermittently, it induces cardiac stunning, and this contributes to heart failure and cardiac death. So is it CRRT better than ultrafiltration to reduce or not to induce cardiac stunning? Will it prevent it? So there was this study done in 2019, looking specifically for CRRT in cardiac stunning. They did an echo before they started the CRRT. Unfortunately, they see that it really doesn't matter which modality we use. And 10 out of the 11 patients in this study, it was a small study with a lot of patients in it, the majority of them end up having a new regional cardiac stunning, despite having stable hemodynamics in many of them. So that's something important as well. It seems that if we are trying to be very aggressive in those patients that have hemodynamically stability, we may cause more damage. And due to the lack of clinical benefit of using CRRT, we cannot say that it is better than just intermittent ultrafiltration. So which are the patients that benefit from CRRT? Specifically, those patients that have very bad hemodynamics. Those are the patients that we will use it as a first-line therapy. In many cases, out of convenience. It doesn't mean that one versus the other modality will cause less hemodynamic changes. We have studies that shows that hypotension across both of the modalities is very similar, but we tend to use CRRT conventionally for those patients that are in cardiogenic shock on several pressors in order to allow the ultrafiltration to be done continuously over time and trying to achieve the goal. These are patients that, regardless of what we try to do, the risk of mortality is very high. They have done studies to see whether we should start CRVVH earlier or later. And these studies, they have not shown yet which one of the two is better. So early CVVH versus waiting a little bit longer. We don't know the answer for that yet. So we use it as needed, and specifically in those patients that we have tried everything else and nothing else worked. The outcomes are similar, whether if you treat it with the different modalities in the setting of AKI. So just to conclude my presentation, AKI is very common. Acute kidney injury is very common in patients with heart failure, and it is an independent risk factor for mortality. The medical management as a first-line therapy, we use stepped IV loop diuretics. We know that they have not shown survival benefit. We use it for the benefit of symptoms on the patients. We don't know which one is the best timing yet for the renal replacement therapy. This is still under debate, which one of the modalities is better. But we know that in general, any of the modalities that we use have not shown survival benefit. So you can see that many of the measures that we use for the management of acute kidney injury in CHF does not show any survival benefit. But we still use them trying to preserve some of the kidney function for longer and trying to improve the symptoms on the patients. Thank you very much for the invitation. I'm happy to entertain any questions you may have.
Thank you, Dr. Maria. It was a very nice presentation, and I think in the presentation you answered most of the questions regarding the use of creatinine, of diuretics like furosemide against a high creatinine. I think we have to use it whenever the patient will need, regardless doubling of creatinine or being high or low, as long as the patient needs decompression.
Yes, don't be afraid that you see a high creatinine, and this is a very common misconception that because of the severe AKI, if we try to give diuretics, we're going to worsen the AKI. In a setting like this one with acute kidney injury and heart failure, we need to get rid of the volume overload. That is causing venous congestion in the heart, and it is also causing venous congestions in the kidneys. So we're trying to decongest the kidneys as well. And if we try to diurese, you're going to see that high creatinine will start to improve. Remember the Starling curve, and it's also important to keep that in mind, that we want to focus on the volume management and that giving IV diuretics at high doses, even on acute kidney injury with high creatinine, it will be beneficial for the majority of the patients. Of course, there will be patients that we're going to get stuck. And even if we try high dose diuretics, it won't help. It won't have any benefit. And those are the patients that unfortunately, we're going to end up needing to do any renal replacement therapies.
Exactly. Exactly. The second question about use of a SLED technique versus CRRT.
Yes, so that is important to mention as well. So SLED means just an ultrafiltration done with a machine that is continuous, right? It's the same machine of the CRT, but we are not doing renal replacement therapy, meaning we're not doing clearance, we're just doing ultrafiltration. And it will depend on what the patient needs. If you see that the electrolytes and everything else is preserved and that you do not need clearance, and there will going to be very few patients that do not need clearance, meaning that the BUN is not super elevated and that the electrolytes are stable, then using a SLED therapy, it is convenient. It helps us in many cases.
Especially that it is cheaper.
Oh, yes, of course. But it will help us in many cases because if the patient does not need clearance, it helps us see how the creatinine moves as we start pulling fluid. When we do CRRT, we lose that. We lose that specific value of the creatinine. We're going to start clearing it. The creatinine is going to start getting better because we're clearing it. And It's not going to help us to determine if we're doing any improvement. We wouldn't know if we're improving until the patient starts making urine on its own. And that will be the indication to stop the CRRT therapy or the SLED therapy in any case.
Okay, last question. Is there any role for peritoneal dialysis in congestive heart failure with suffering from chronic kidney disease or acute kidney disease?
Yes. So unfortunately, we do not have a lot of literature or experience in the use of peritoneal dialysis in the acute setting. It is not conventionally done here in the United States. If you go to other countries, you will see that peritoneal dialysis is fairly used in acute settings. So, yes. And it's cheaper. So I think it does have a benefit. You can see how by the use of it, the hemodynamics is better. So it's more not stable. As invasive in that perspective, but we do not have a lot of data on it. And it's just mainly that because conventionally here is not used acutely.
We have to mention that Mexico is one of the biggest countries using peritoneal dialysis, and also I would share with you over the email one of our experiences in Egypt. We were using peritoneal dialysis in managing of heart failure and renal failure, and it was a very good story. I will share it with you.
I believe you. I am a believer that peritoneal dialysis should be the future for many of these patients, because you are not causing as much hypotension that you will be causing with other modalities through vein. And it's a little bit more gentle from that perspective. You're going to see that I assume by using the ultrafiltration that way from the peritoneal dialysis, with patients that are appropriate for that modality will benefit from it, definitely.
Okay, now we will move for the time, because of the time factor, we are delayed by 20 minutes. And I'd like to apologize for Professor Lotfi Al-Korbi. Professor Lotfi, can you please stop sharing your screen?
Yes.
Yes. Professor Lotfi Al-Korbi is a consultant nephrologist and the head of nephrology department in King Faisal Specialized Hospital. He has many publications and achievements in the field of nephrology in Saudi Arabia, and he was one head of the program of home hemodialysis. And mashallah, we all need to hear from him and need to know his experiences in many fields. Thanks, Dr. Lotfi, for joining us. And you may share your screen, please. Dr. Lotfi, you can.
Okay, Assalamu alaikum. Do you see my screen now?
Yes, yes, sir.
Yeah. Okay, thank you very much, Ahmed, and thank you for the nice introduction. And I have two presentations today. So the first one is about the hyponatremia. We define hyponatremia by serum sodium below 135, and hyponatremia is a pathophysiological process indicating a disturbed water homeostasis. Is an independent predictors of death in patients with cancer, heart disease, and cirrhosis. Hyponatremia is associated with poor outcome, such as reduced survival, prolonged hospital stay, and increased cost. Now, when we talk about sodium, we always have to think about the body fluid compartment. And you all know that we have the 2/3 and 1/3. 2/3 of our total body water is in the intracellular, and 1/3 is in the extracellular. And I just want to focus with you that where is really the water, the extracellular, 6 or to 7% the plasma, and we have 10% in the bone and connective tissue, 3% in the adipose tissue, and 20% in the interstitial. Now, hyponatremia is a prevalent abnormality, and this is the prevalence of hyponatremia in 4 different countries, and you can really see that it's ranging from 17 to 30% prevalence of hyponatremia. Now, what is the pathogenesis of hyponatremia? Hyponatremia, it could be delusional or depletional. This is the Edelman equations, which says that serum sodium is equals serum sodium plus serum potassium over total body water. So when we talk about hyponatremia, which is decreased serum sodium, we will have either reduce the numerator, which is the serum sodium or serum potassium, or increase in the denominator, which is increase in the total body water. Now, most of the time when we see hyponatremia in the hospitals, the cause of the hyponatremia is going to be a multifactorial. You can have a patient with a renal impairment, you can have a patient dehydrated, congestive heart failure, a patient taking medications. So most of the time what we see is a multifactorial etiologies of the hyponatremia. This is a case that I saw in September, so I want to show you the case, and I will show you at the end of my presentation how this patient was managed, because this patient presented with a severely symptomatic hyponatremia. 69 years old female, known with ischemic cardiomyopathy and post-coronary artery bypass surgery and left ventricular aneurysm repair in 2006. Also known to have diabetes and hypertension, and she has severely impaired left ventricular systolic function with estimated ejection fraction of 30% and moderate mitral regurgitation. She presented to our hospital's emergency department with shortness of breath and edema. And her daughter at that time, she said that she noticed that she has been delirious and says things that they don't make any sense to them most of the time. She's also having nausea and vomiting for 2 days, and she became wheelchair bound because of her edema. So when we saw her in September, her blood pressure was 154/78, her heart rate was 103, temperature 37, respiratory rate 23, oxygen saturation was 97% on room air, and she was disoriented to time, place, and person. She was lethargic. She's having bilateral lower limb edema and bilateral respiratory trickles. Her serum sodium was 104, and her serum osmolality was 225 millimoles. So she's having a severe hyponatremia. At the end of my presentation, I will just show how this patient was managed. So this is what we usually do when we really approach a patient with hyponatremia. The first thing is that we measure the serum osmolality, and based on that, we will divide the patient into hypotonic hyponatremia or non-hypotonic hyponatremia. So if the serum osmolality is below 275, then we measure the this is hypotonic hyponatremia. and we measure the urine osmolality to decide about whether this is a high ADH or a low ADH cause of the hyponatremia. If the urine osmolality is high, so this is ADH-mediated hyponatremia, and those are going to be the etiology. If the urine osmolality is low, in that case, a patient with hypotonic hyponatremia and urine osmolality is below 100, this means that this is not an ADH-mediated cause of hyponatremia. And the most likely cause is going to be polydipsia, beer pneumonia, or low solute. Now, most of the cases that we really see in our hospital, and I think worldwide, is that with hyponatremia is hypotonic hyponatremia with a high ADH or ADH-mediated hypotonic hyponatremia. In that case, we divide the patient into 3 categories. Is it hypovolemic, euvolemic, or hypervolemic? And based on this, if it's a hypovolemic, is it because of loop diuretic? Is it because of GI loss? Is it because of cerebral salt wasting? And if it is euvolemic, the most common example is going to be SIADH, but we really have to rule out adrenal and hypothyroid disease. Now, if the patient is having the urine sodium below 20 and they're hypervolemic, we call it hypervolemic hypotonic hyponatremia. And the classic example is going to be congestive heart failure, cirrhosis, and nephrotic syndrome. So this is a hyponatremia, either hypotonic or non-hypotonic hyponatremia. So if we just focus on the non-hypotonic, it means that we have a patient with low serum sodium, but the serum osmolality is not low. What is the etiology of this? So those are the common etiology of a patient with hyponatremia and normal or high serum osmolality. Hyperglycemia, mannitol, patient who receive radio contrast, pseudo-hyponatremia, and in most of those cases, treatment is going to be conservative. So pseudo-hyponatremia, the common things was going to be because of high triglyceride levels or high protein levels like multiple myeloma. But also this could be due to exogenous osmoles like the contrast dye, mannitol, maltose, or sorbitols. This is pseudo-hyponatremia, and I just want you to see on the left side here is the normal extracellular fluid, and in the right side is a patient who's having hyperproteinemia. Now, we know that in 1 liter of the plasma, 93% consists of water and only 7% consists of lipids and protein. However, in a patient with hyperproteinemia or hypertriglyceridemia, this solute part is increasing, and that's why the lab's going to report that the serum sodium is low. But in fact, it's not low if you really compare it to the amount of the solvent here in the plasma. Now, so we talked about the non-hypotonic hyponatremia. What about now about the most common, which is a patient with hypotonic hyponatremia? As we mentioned, we categorize the patient into hypovolemia, euvolemia, and hypervolemia. And again, we always go to this diagram to classify where our patient is in his or what is the etiology of this low sodium or hyponatremia. So what are the causes of hypotonic hyponatremia? We have either it's going to be because of decreased water diuresis or excess water intake. So let's talk about decreased water diuresis. And those are the 3 etiology: hypovolemic hyponatremia, hypervolemic hyponatremia, and euvolemic. Hypovolemic hyponatremia, it means that the patient lost a lot of fluid, and this could be through the kidney or through the non-kidney signs of blood loss, diuretics, or osmotic diuresis. These are some of the etiology of volume loss in the kidney, or if the patient having a GI loss like vomiting, diarrhea, or if the patient has sequestration like pancreatitis, peritonitis, or massive trauma. Now, the non-renal loss, as we said, GI loss, vomiting, diarrhea, GI gastric tube drainage, hemorrhage, and sweating and burns. And the renal loss is diuretic, especially thiazide and post-obstructive diuresis. Now, in hypervolemic hyponatremia, the etiology is heart failure, liver cirrhosis, nephrotic syndrome, kidney failure, acute or chronic, and also in pregnancy. Now, euvolemic hyponatremia, a patient may be taking thiazide in certain cases, because those patients thiazide, they present with euvolemia. It could be severe hypothyroidism, glucocorticoid deficiency, or low solute intake like tea and toast diet, beer with ammonia, and dilute infant formula in the infant, and syndrome of inadequate antidiuretic hormone secretion. So those are the differential diagnosis of euvolemic hyponatremia. And as you can see that SIADH is the predominant cause. When you see hypotonic hyponatremia with euvolemia, there are many etiologies of why ADH is high. So we really have to rule out medication, specifically the antipsychotic medication, SSRI, and we also need to rule out anti-epileptic medication like carbamazepine and valproate. Other causes of a high ADH could be ecstasy, malignancy, especially the small cell lung cancer, neuropsychiatric disorders, severe respiratory failure, and sometimes in the post-operative T2 pain or nausea. Now, this is the relationship between the plasma antidiuretic hormone or AVP with the plasma sodium, and you can see that as the serum sodium decreases, the ADH is usually suppressed. And whenever we have a serum sodium increase, usually our ADH hormone is really increasing. So to diagnose syndrome of inappropriate antidiuretic hormone, we have to have a low serum osmolality, high urine osmolality, high urine sodium to exclude hypovolemia as a cause of high ADH. Patient has to be clinically euvolemic with normal organ function, normal hepatic, renal, and cardiac, thyroid, and adrenal function. And obviously, the patient should not really have been on recently on a diuretic. Hyponatremia with a low urine osmolality, and the differential is here is 3 causes that will cause the patient to present to us with hyponatremia, and his serum serum osmolality is low as hypotonic hyponatremia, but the urine osmolality is low as well, and this is what we call it low urine osmolality hyponatremia. And the best example is psychogenic polydipsia, so the patient is drinking a lot of electrolyte-free water, and beer, bitumonia, excessive beer intake with a reduced solute intake, and elderly patient who eats tea and toast diet, which is essentially low solute intake. Those usually present with hyponatremia with low urine osmolality. The second cause of hypotonic hyponatremia is going to be excessive water intake, and excessive water intake is going to be primary polydipsia, or exercise associated, and sometimes it's with the irrigant solution in the surgeries like hysterectomy or laparoscopic surgery. We need to remember that even potassium, when we have hypokalemia, that may cause hyponatremia, and the potassium increases tonicity as much as sodium. So the estimated increase in the serum sodium is going to be the potassium over 0.5 times the weight in kilogram. Now, how the patient with hyponatremia presents? Now, the patient may present acutely or chronic. Most of the patient, they present acutely if they're really in the hospitals, and most of the patient that they present to the emergency, they're really having a chronic hyponatremia. The symptoms is really depends on the acuity and chronicity of the hyponatremia. So usually acute symptoms are very severe, and the patient may even present with seizure and coma. And most of the patient with chronic hyponatremia, they have no symptoms. And the reason is that because of the CNS adaptation. So when we have a slow onset there is always CNS adaptation, and the patient may have no or only mild symptoms. But in acute presentation, the onset is going to be rapid, and there will be no enough time for CNS adaptation, and the patient will present with a severe symptoms like seizure or coma. So what are the symptoms of hyponatremia? Asymptomatic is common. Mild, non-specific symptoms: nausea, vomiting, fatigue, headache, confusion, delirium, seizure, coma, or respiratory arrest. Those are the severe symptoms. So when we see a hyponatremia, we divide the symptoms into severe or non-severe. So whenever we have a patient with hyponatremia have seizure or delirium like our patient, or coma or severe confusion, we know that those patients already having brain edema and they have a very severe form of hyponatremia. However, when a patient with low serum sodium having nausea, vomiting, headache, mild confusion, stomach gate instability, they can still have hyponatremia, but that's really not a severe form of hyponatremia. How we treat hyponatremia? We have emergency treatment and we have non-emergency treatment. So symptomatic hyponatremia has an unacceptably high mortality rate unless it's treated aggressively and correct, but to a safe level. So whenever we have a symptomatic hyponatremia, we really have to try to correct the serum sodium to a safe level quickly. However, over-aggressive therapy leads to crippling or fatal neurological complication known as osmotic demyelination syndrome. And fear of complication from hyponatremic encephalopathy does not justify therapeutic access. Overcorrection should be viewed as a medical emergency, and we should really always strive to overcorrect hyponatremia. So we always have to balance the risk and benefit when we really try to manage hyponatremia. And this is the osmotic demyelination syndrome. And this is cerebral edema. You can see here the ankle. If the cerebral edema happens in a patient with a severe hyponatremia, he can end up of herniation. However, if we really a patient with mild or no symptoms and we try to overcorrect, we may end up causing osmotic demyelination syndrome. So what are the guidelines saying about the hyponatremia? We have the American and the European guidelines in the management of hyponatremia. The American saying that if you have a severe symptomatic, you need to give 3% saline with 100 ml over 10 minutes, and you can repeat it 3 times. And the European is the same. They're recommending a bolus of 3% saline. But here they're recommending 150 ml over 20 minutes. And again, you can repeat it as needed. The moderate symptoms, the American guidelines, they would prefer a continuous infusion over the bolus, which is 0.5 to 2 ml per kg per hour. And European, they still could recommend to give the bolus of 3% saline, 150 ml over 20 minutes. The minimum increase in the serum sodium is 4 to 8 per liter per day in the American, and they're recommending 4 to 6 per day in high risk for osmotic demyelination syndrome, and they limit 10 to 12 millimole per day and 8 millimole per day for a high risk patient of osmotic demyelination. Now the European guidelines limiting the correction of the serum sodium that should not exceed 10 millimole per day. Both guidelines commenting about the overcorrection, and if the serum sodium is more than 20, probably you don't really need to do anything about the overcorrection. However, if the serum sodium is below 120, the American guidelines would recommend desmopressin and after if the correction exceeds 8 millimole per day. The European, they're really recommending to give electrolyte-free water with or without desmopressin. When we see a patient with a hyponatremia and we like to treat, we always apply the infusate formula so that we can really know exactly how much fluid and what kind of fluid should we give. And the serum sodium should equal the sodium plus potassium in the infusate minus serum sodium over total 3+1. Now, this is the estimate effect of a different formulas. 3% saline has 513 sodium and this is the sodium and potassium, and the effect in per liter is around 13 millimole. And you can see that normal saline almost has a neutral effect in the management of not hypovolemic hyponatremia. Again, ringer lactate would have really no effect on this patient. We always need to know that if the patient is really lost fluid, then we really have, or becomes polyuric, then there's a formula called fluid loss formula, because of the patient developing polyuria, he may overcorrect, and we really need to be careful on assessing the volume of the patient and the urine output. And those are also the effect of the infusative fluid loss based on the urine output. Now, is there any difference when we try to correct or treat hyponatremia? Should we give a bolus or infusion? This is a trial called SALSA trial, which compared infusion of hypertonic saline to a bolus. And the primary outcome was overcorrection at any given period, defined as increase in the sodium more than 12 in 24 hours or in 24 hours. And the secondary was efficiency. So what they found that there was no difference between these, either you use continuous or a bolus of hypertonic. Now, in the chronic hyponatremia due to syndrome of Fabry ADH, how should we treat? We need to restrict the fluid, and we really need the restriction of the fluid based on the urine sodium and plus potassium, because sometimes we can estimate or know that who is going to respond to the fluid and who may not really respond to the fluid restrictions. So the urine sodium plus urine potassium over the plasma sodium is more than 1. We recommend the fluid intake to be less than 500, and which is most likely the patient is not going to really respond to that. However, if this ratio is 1 or below, most likely that the patient would respond to the fluid restriction. We can give dimicrocycline, which is 300 to 600 milligrams twice a day, or urea 15 to 60 grams per day. And we can give also vasopressin receptor antagonist if it is available. The predictors of good response is urine osmolality to fluid restriction. Urine osmolality is more than 500. Urine sodium plus urine potassium over plasma sodium more than 1. And urine flow is below 1.5 liters per day. So if the patient is not responding to the fluid restriction, then we have to go to medication. And this is tolvaptan, which is works on the V2 receptors, which is the same receptors of ADH. So tolvaptan is going to block these receptors and is going to decrease the water absorption, and it will cause aqueresis. The side effect of tolvaptan is 2 things. One is hepatotoxicity, so that we really have to watch for this. And of course, it may lead to overcorrections of serum sodium. Urea is another agent that can be used if the patient did not respond to the fluid restrictions, and if we don't really have the ADH receptor antagonist like tolvaptan. It is safe, and it was tried in multiple trials, and this is the trial that they compared, they use urea, and they found that the urea is effective in improving the serum sodium with no over correction. Now, do they differ, urea and Vaptan? Is there any one is better than the others? So they compared urea and Vaptan. So this is a long-term management of SIADH and hyponatremia. Initially, they treat them a patient with Vaptans, and then there's a wash period. and then they give them urea. And what we can really see that after 1 year, here is 12 patient, they use urea 15 to 30 gram per day, and 1 episodes of hypernatremia. And we're really looking, comparing it to the VABCAN, you can see that 13 patient, 1 dropped for excess thirst, but they were really, end result were equivalent serum sodium went here corrected from 125 to 135. And here from 126 to 135. So urea or VABTAN has equivalent efficacy in the management of euvolemic hyponatremia, that not really responding to fluid. How we anticipate overcorrection is always a problem, that when we try to treat hyponatremia, we may overcorrect. If overcorrection occurs, treat with hypotonic fluid and the DAVP. And one of the concerns of overcorrection is this disease, which is osmotic demyelination syndrome, which is demyelination of the pontine and extrapontine neurons. It is usually a iatrogenic complication, result from rapid correction of chronic hyponatremia. Result from overcorrection of serum sodium, usually more than 12, but can occur even if we overcorrect more than 8 milliequivalent per day. Symptoms of osmotic demyelination include quadriplegia, pseudobarbar palsy, locked-in syndrome, seizure, coma, and even death. The diagnosis is by MRI, which will show the demyelination. And unfortunately, there's really no treatment for this. And now we know that osmotic demyelination usually occurs with overcorrections. And if the overcorrection is especially if the serum sodium initially is below 15, and if we overcorrect more than 8, there is a high risk of osmotic demyelination. However, if the serum sodium is more than 115 and we overcorrect, the risk of osmotic demyelination is lower. Osmotic demyelination syndrome can occur in patients with chronic hyponatremia with a serum sodium below 115, despite rate of serum sodium correction less than 10 hours. And we recommend chronic hyponatremia to be corrected by less than 8 milliequivalent. So how we manage the overcorrection? So this is the time, and this is the serum sodium. Target is 6 to 8 millimole per day. And if there is an overcorrection here, then there will be a risk of osmotic demyelination syndrome. So we really have to use the DAVP and D5 water so that we can bring the sodium back to the acceptable level. So back to our patient who is having cardiomyopathy and having severe hyponatremia of 104 and low serum osmolality. So this is a patient that we saw in September 2022, and when he presented to us, here is time in hours and here is the dates. And this is initially when he presented, his serum sodium was 104 and he was symptomatic. Initially, because he was having some edema and congestion, he was given Lasix 80 milligram IV, trying to diurese him, hoping to improve his serum sodium. But in fact, his serum sodium worsened, and after hours, serum sodium was 101. So it even went worse. So here they increased his Lasix and they tried to give him 120 milligram IV of Lasix, but again, the serum sodium went up a little bit back to 103. So he's still having no significant change in his serum sodium after good doses of IV Lasix. Now, after the 120, it's increased to 103. Now here, because of the severity of the symptoms, they decided to give the patient 100 ml of 3% saline after around 13 hours from his presentation. And serum sodium is improved to 104 after 4 hours, but all of a sudden it increased to 115. And in fact, after a time it went to 124. So this patient is overcorrected. Initially, he was having a poor response to the diuretic, but when he received 100%, 3% saline, he overcorrect. So what we did here, because of the overcorrection, and we're really worried about the osmotic demyelination syndrome, we give the patient DDAVP 2 microgram IVQ 8 hours, and we give the patient 2 liters of D5 water. The serum sodium dropped from 124 to 118, so we were happy to see that. And then it dropped to 117, that will be great. However, a few hours later, it started to increase again, so we really have to give another liter of D5 water. Now, when we looked back, why the patient's overcorrect here, we found that he's becoming polyuric and his urine output increased here, and he becomes polyuric and his urine output was 200 ml per hour. And this is really behind why he overcorrect here. So we discontinued Lasix at this moment. And after we discontinue the Lasix, you can see that the response here is not only to the DDAVP that decreases serum sodium, also his urine output decreased from 200 ml per hour to around 40 ml per hour. So this is a patient who presented with a severe symptomatic hyponatremia and some form of heart failure that he initially did not really respond the IV Lasix, and he received 3% saline, but he overcorrect, requiring to be given DDAVP and D5 water to bring his sodium back to the really acceptable level. I think this is my last slide. This is the fluid loss formula that we already discussed. Thank you very much.
Thank you, Dr. Lotfi. It was a very nice presentation. I have one question maybe I missed in the case presentation you did. Why initially we started with Lasix? He was overloaded?
Yeah, so this is a patient who is having a congestive heart failure, and he came with edema and fluid overload. So the treatment initially was Lasix, and usually those patients, if they diarees, they will their serum sodium will improve. But unfortunately, it didn't happen in this patient.
Maybe there was too much natriuresis when we start with Lasix, right? So
no,
no,
usually because with Lasix you lose more water than sodium. So usually we would expect the serum sodium to go up because we're really, when we give Lasix, we lose more water than sodium. So we're expecting that the hyponatremia will improve with giving Lasix. And this is the treatment of hypervolemic hyponatremia. The treatment of hypervolemic hyponatremia is Lasix, is trying to get rid of the extra water. So in a patient with a liver cirrhosis or congestive heart failure, or even nephrotic syndrome, if they're really having hyponatremia and they're having excess fluid, Lasix or diuretic is the drug of choice.
And in this case, if Vaptans were available, would you use Vaptans instead of Lasix, like Convaptan?
No, now Vaptan is not used in the acute hyponatremia. And I have to mention that we should not really use Vaptans in the acute hyponatremia. Vaptans or urea is only used in chronic hyponatremia.
Okay. Yeah. Is Vaptans available now in the market?
Sorry?
Vaptans, Convaptan is available now in the market?
I don't think it's available in Saudi Arabia.
I have one patient who is bringing it from Turkey.
Yeah, I think now Vaptans has another indications, and people now is using it for polycystic kidney disease as well.
Exactly.
So,
yes.
Yeah, so maybe we are going to see it in the future because now there is two other indications, or there's another.
I heard that there will be a generic Convaptan here in Saudi Arabia, in the local market. Saudi company will do it.
I think if we don't have a 12 Vaptan, then we can really use urea. Urea is a cheap and it's really used in Europe, and now is even approved in the US. So I think it's cheaper and can also be used. Don't have Vaptans available, but I agree
urea
really
available in the market.
Also here, I'm not sure about the urea. We don't have it in our hospitals, unfortunately.
Exactly, me too.
I think it's very important, honestly, because we do have a patient with SGH or hypotonic hyponatremia, they're not responding to the fluid restriction, and unfortunately we don't really have urea or plants available with us, so we really trying to manage them conservatively without use of medication. And I think in some patient you will need one of these medications.
Okay, we have some few questions here. The first one, what do you think about use of SGLT2 inhibitors in SIADA syndrome?
We don't have, or at least I did not come across any study that used SGLT2 inhibitors in the management of hyponatremia. Now, but I will not really advise, because the problem is that SGLT2, you're going to lose sodium and it may really make it worse. So I don't really have any studies that look into that, but I would not really recommend it without really a clear evidence that it showed a benefit.
Okay. Second question: if there is concomitant hypokalemia with hyponatremia, do you like to replace potassium first or sodium? And if correction of potassium can affect the correction of sodium?
So you're correct. That's a very good question. So you always, each 1 milliequivalent of potassium like 1 milliequivalent of sodium. So you can really combine, for example, you can give normal saline or half normal saline with 30 or 40 milliequivalent of potassium. Yes, that would be the treatment of choice. And you really have to know that, yes, if you correct hypokalemia, you will also correct hyponatremia. So yes, sodium and potassium is going to increase.
Can be corrected in the same time.
Yes, you can correct them at the same time. Most of the time, of course, we need to follow any patient who's coming with symptomatic hyponatremia. The best thing is that you really have to follow serum sodium, and you monitor it closely. We usually do it every 4 hours so that we can really see if the patient is responding to our therapy, if the patient is going to the right direction, or if the patient is overcorrection. So any patient with symptomatic hyponatremia, you cannot just give a treatment and without monitoring. Those patients usually require monitoring at least every 4 hours. You repeat the serum sodium so that you can modify your treatment whenever either the treatment was not effective or there was overcorrection.
What is the management of hyponatremia in heart failure patients who are already on diuretics?
This is what I say. As far as the patient is in heart failure, then you need to maximize your diuretics. You really have to give a higher dose of a diuretic. Now, if the patient is becoming diuretic resistant, he's not really responding to the diuretic, and he is having a renal failure, of course, the treatment is going to be a dialysis. So if you're really having a patient that with cardiorenal syndrome, that he's having heart failure and renal failure, that he's not responding to the diuretic, dialysis is going to be the treatment of choice. However, if the patient is coming with acute kidney injury and you think that this is because of the cardiorenal and you want to give him the Lasix, he did not respond, maybe you want to try a 3% saline. This is like what was tried in this patient. This would be as acceptable as far as the patient is not severely fluid overload.
Okay, now I think we can call Professor Ashraf Hussein. Dr. Ashraf, are you still with us? So I think we may stop sharing this one, yes. Okay, if Dr. Ashraf is not available, we may go to the second presentation, the one interesting presentation about use of IV fluids. We have been using IV fluids as an innocent treatment, but with Dr. Lotfi Al-Korbi, he will tell us that using IV fluids is not that innocent management, and it may have some harm effect on our patients. For me as a nephrologist, I only know that using too much of some IV fluids that we use, like when we replace post-transplant patients, we may suffer from lactic acidosis or hyperchloremic acidosis with using too much fluids. But I think we all have to hear from Professor Lotfi how to use intravenous fluid without harming our patients. Thank you, Dr. Lotfi, for choosing this nice topic, and we are here to hear from you.
Thank you very much. I think the intravenous fluids in the last few years, there's a lot of literature about these topics, and I think we learned in the last decades that we really have to be more conservative and not liberal on IV fluid. So hopefully in the next 30 minutes, we're going to go over some of the studies that looking into the type, the dose, and the different formula of the IV fluids. So the invention of IV fluids started 200 years ago. This is by Dr. Lata Thomas in 1832. And this was in the epidemic in England and Scotland. He published his articles in Lancet, and he described injecting salty water into the basilic vein is an increasingly large volume in patients with thermal cholera with remarkable result. By the end of 1880, the treatment had finally been established, and IV fluid was used. Few years later, Sidney Ringer created another solutions that contains other electrolyte like potassium, and this was at the end called the Ringer lactate. Now, the commonly used IV fluid is crystalloids, and we have normal saline, and we have a balanced solutions, which is one of them is a Ringer lactate. There's another solution called plasma light. And we have the colloid solutions, and the best example is the natural colloid, which is albumin, or the synthetic colloid like hydroxyethyl starch and gelatin. Now, this is the composition of the most commonly used IV fluid. And the left side here is the plasma. And you can see that this is 0.9 sodium chloride, Ringer lactate, plasma slide, and albumin. And one thing about the sodium chloride, that if you really look and compare it to the plasma, that it is really having a high high chloride content. And this is one of the reasons that this is really, there's a lot of data about this as maybe is causing an acute injury because of the high chloride content of the normal saline. This is the Ringer lactate, which you can see that the chloride is similar to the plasma, and even the osmolality is low, but this high osmolality. And those are the other electrolytes and other solutions, including 4%. Now, we all know the indications of intravenous fluid. We always use it for resuscitations, for maintenance, and as a replacement fluid, and we are also using it in nutrition. The main goal of fluid administration is to ensure adequate tissue perfusion by increasing the intravascular volume. And we always, and we at the same time know that too much fluid may lead to the formation of edema, which can negatively affect the function of various organs, such as the lungs and the kidneys. We already talked about the body fluid comportment hyponatremia, so I'm not going to repeat it, but this is the total body water, 60% intracellular and 40% extracellular. And when a patient presents with shock, we know that there are four types of shock: distributive or septic shock, hypovolemic shock, cardiogenic shock, and obstructive shock. And we, especially if the patient having hypovolemic shock, we may really need to give some fluid to resuscitate those patients. However, we really need to know the shock types and the preload, cardiac output, SVR, and the filling pressure in each shock, so that we can really decide how to give fluid to each of those patients. Now, the Surviving Sepsis campaign guidelines last year for the resuscitation of the fluid, they said that for patients with sepsis-induced hypoperfusion or septic shock, we suggest that at least 30 ml per kg of IV corticosteroid fluid to be given within the first 3 hours of resuscitation. Although this is having a low quality of evidence, but this is the standard of care nowadays, that that patient will be resuscitated with this type of fluid. Now, we know the risk of hypovolemia for a long time. Nowadays, we start to also know the risk of hypervolemia. So both hypovolemia and hypervolemia having a risk. Now, this is the risk of complications, and the relationship between hypovolemia and hypervolemia is a U-curve. So a patient will have a complication if they have hypovolemia, and they will have a complication if they're also having hypervolemia. So we're really having, or what we really need, the patient to be in the AU balance. Now, volume overload, we know that it will cause pulmonary edema and will cause fluid overload, but we also realize that volume overload also is causing release of inflammatory markers. So this is the blood vessels, and this is the endothelium. And whenever there is a high flow in the blood vessels, like in a patient with fluid overload, they will be a shear stress, and there will be a pressure on the endothelium, and this will damage the endothelial and cause a release of the inflammatory markers. And this will cause a leak of the fluid from the vessels to the outside the vessels to the interstitium, and that's why you see this capillary leak. You see mainly in a patient with fluid overload or in a patient with severe sepsis or septic shock. Now, too much fluid is detrimental, and this is what we always saying, that if you really give too much fluid, you can cause edema in all of the organ, cerebral edema, pulmonary edema, myocardial edema, hepatic congestion, venous congestion, and this will lead to acute renal failure, and even gut edema as well. So there's no question that too much fluid is detrimental as well. The problem is that how can we know whether the fluid that we're giving is enough or not? So this is the Starling curve, which looked at the left ventricular preload and the stroke volume. And you can see that as we increase the preload, for example, by giving fluid, the stroke volume is increased, which is this what we are calling what we need. However, there's always a time that that is not a preload dependent, that whenever we exceed this area or this zone, the patient will be turned from preload dependent to preload independent. And there, if we continue to give fluid, there will be no improvement in the stroke volume, but there will be more of fluid overload. Usually, once we identify this period and the patient is still hypotensive, and what we need to do is we need to give the vasoactive medications. Now, this is the different response. We know that not all the patients will respond the same. This is two different patients, and you can really see that this is the inadequate preload. And this patient, when you increase the preload, left ventricular preload, the stroke volume is increased. However, he has the optimized is lower than the other patient, which is really, if you really give more fluid, his stroke volume will increase even more. So also a patient has to be individualized because they respond differently from to fluid administrations. This is the response to fluid loading in normal and failing heart. This is a failing heart and this is a normal heart, and you can see that those two patients has the same CVB. However, the first patient, if he really, if the ventricular preload is here, more volume is going to cause fluid overload. However, if the patient having a normal heart, if you give more fluid, his stroke volume will increase. Now, this is a very important slide that we always has to look at it carefully. Now, we said that left ventricular preload and stroke volume relationship. As we give fluid, we increase the left ventricular preload, the stroke volume will increase from A to B. However, if we give more fluid, once the patient reaches B to C, there will be no increase in the stroke volume. However, there will be a significant increase in the lung volume. And that's why there's a narrow period between fluid optimization and overload. So if you continue to give fluid, and already the patient in this point in unit E, there will be no improvement in stroke volume. However, there will be a significant increase in lung volume and fluid overload. So we always need to know what is our green zone here, that above which we should not really continue fluid, and in fact, we should really move to vasoactive medications. We need to assess the volume in any patient who really needs the volume. And we have static measures that unfortunately, they're not really reliable, like the CVB, the urine sodium, serum lactate, IVC diameters. Unfortunately, they're not really reliable. The CVB is only reliable if it is very low or very high. Most of the patients that we see in the ICU or the emergency, their CVB in the middle, and this doesn't really help in assessing the volume of the patient. The surviving sepsis campaign recommending to use a dynamic measures like pulse pressure variation, stroke volume variation, passive leg raising test, fluid challenge, or pulse contour analysis, or echo. Nowadays, there is a point of care ultrasound that can help us in assessing the volume status in critically ill patients, like lung ultrasound and IVC ultrasound. So this is what survival as the surviving sepsis campaign guidelines is saying, that for adult with sepsis or septic shock, we suggest using dynamic measures to guide fluid resuscitation over physical examination or static parameters known. Now, this is one of the very simple tests that studied very well, which is the passive leg raising. And this is a meta-analysis of 21 studies of almost around 1,000 patients. And they found the sensitivity of specificity of the passive leg raising in assessing the volume is almost 95%. Now, I have to tell you that the sensitivity and specificity of CVB, which is really using it commonly, is only 50%. Echo or echocardiogram could be helpful in assessment of a patient with shock before we give any fluid. This is a patient with hypovolemia. You can see that the right ventricle and the right atrium is very collapsed, so this patient is hypovolemic. Here's a patient with a tamponade, so that you can see a pericardial effusions. And here you can see a patient with a pulmonary embolism where the patient has a very severely dilated right ventricles and right atria. And this is the patient with cardiogenic shock, and you can see that he has severely dilated ventricles and atria. Now, nowadays, which is really available, it's the point of care ultrasound, which is really helping us to assess the volume of the patient. We can really use it to look at the lung. And this is a point of care machine, so that you can really use it to look at the lung. We can also look at the heart, inferior vena cava, hepatic vein, portal veins, and even intrarenal venous tubular. So we really have to look into all of these if we really need to assess the volume effectively. And here, what you're going to see by the point of care ultrasound in the venous congestion, and the left side is no congestion, and then the right side is the severe congestion. So if we really use the point of care ultrasound, we really have to be familiar with the normal and the abnormal changes in the ultrasound. Of course, it is operator dependent. It really needs training. But this is the IVC, and here you can see it in the patient with no congestion. And if you really compare it to the severe congestion, which is very dilated, here's the hepatic veins, and you can see the waves of the hepatic veins in a patient with no congestion to how the hepatic vein ultrasound look in a patient with a severe congestion. The same things with the portal vein and with the intrarenal vein. So this is now commonly being used for assessing fluid in the critical and care area and emergency department. So fluid therapy, when we have to give fluids, we have to decide of the dose, timing, and choice of the fluids, and we have to choose the appropriate type of the fluid, and we have to give the appropriate amount, and we also have to remove the fluid when it's really not necessary or when the patient recovery begins. Now, this is the 4 phases of resuscitation of any patient in shock. This is a rescue, and this is a very important. This is the time when we give the fluids. It's a life-saving. A patient coming with a severe shock, severe hypovolemic or septic shock due to vasodilation. We really need to be generous in hydrating him at this time. The second stage after a few hours is optimization, which is we try only to give a maintenance. And here's the third stage. We always have to ask ourselves, do we really need to give fluid or not? And most of the time, we stop the IV fluid at this stage. I just want you to remember that after you rescue the patient in the 4th stage, you really need to remove the fluid that we use it in the resuscitation. Now, this is one of the first trials that we learned from it that liberal fluid is toxic. So this is called a FACT trial, which is the fluid management in a patient with acute lung injury and mechanical ventilation. And they want to know from this study which is better, fluid liberal or fluid conservative approach in a patient with acute lung injury or mechanical ventilation. So they have 1,000 patients and they randomize it. They randomize them to 1 to 4. This is a protocol management, fluid management. And they looked at the CVB and the pulmonary artery occlusion pressure. And the conservative, their CVB will be below 4. And the liberal, their CVB is 10 to 14. And the liberal, and the conservative, their pulmonary artery occlusion pressure less than 8, and the liberal 14 to 18. Now, after 7 days, the balance in the conservative was almost neutral. So those patients, in fact, after 7 days, they have a negative 136 ml. But the liberal patient were around 7 liters positive. So what did they find in the study? They found that the death, there is no difference in mortality. However, when they looked at the ventilator-free days and the ICU stays, they found that those patients on the liberal fluid administration, they stay more in the ventilator and they stay more in the ICU. And there is no advantage of liberal fluid when we talk about renal failure. So there is no difference whether you give a lot of fluid or a conservative fluid in the renal failure. So they conclude from the study that although there was no significant difference in the primary outcome of 60 days mortality, the conservative strategy of fluid management improved lung function and shortened the duration of mechanical ventilation and intensive care without increasing non-pulmonary organ failure. Fluid response decreases rapidly in sepsis. So if we have a patient, this is a study looked at 424 patients with sepsis. And this is 0 hour, 2 hours, 4 hours, 6 hours, and 8 hours. And I just want you to look at the responders to the fluid administration, which is the red color here. Initially, when the patient presents with severe sepsis, almost 60% of them respond to the fluid. But look, as we go down on time, the response to the fluid is really decreasing. So if we continue to give fluid, the patient will have no response. In fact, this fluid is not going to improve the hemodynamics of the patient, but it will cause fluid overload. So, and this is a trial which was done in 2016 called Classic Trial, which they took 151 patients randomized to restricting volume. There's a standard care or in a patient with septic shock, and what they looked at the co-primary outcome, which is the first 5 days randomizations, and they found that the fluid restriction has a lower co-primary outcome comparing to the liberal fluid, which is increasing to stay in the ICU and ventilator dependent. Now, this is the meta-analysis. The meta-analysis of 20,000 critically ill patients associated. There is association between the positive fluid balance and the outcome. Here we have 11 randomized control trial and 24 observation trials. And what we see here is that if we looked at the y-axis, which is the cumulative fluid balance, you can see that the green bar is those patients, the survival, that the fluid balance in the survival was around 2,400. And look at the non-survivals, the fluid balance is almost 7,000. So those patients who's really having significant fluid, or they were treated with a lot of fluid, they have a less survival than those patients who's really treated with restrictive form of fluid. And this is the intra-abdominal hypertension. Again, less intra-abdominal hypertension in a patient who's treated with conservative approach than a patient who's treated with a liberal approach. Now, this is in a patient with pancreatitis. Now, we used to give a lot of fluid to a patient who's presenting with pancreatitis. So is the fluid beneficial in a patient with pancreatitis? Should we give more fluid? This is randomized control trial, 249 patients, 18 centers. A patient with acute pancreatitis, they randomized them to aggressive resuscitation or moderate resuscitation. So in the aggressive resuscitation, they gave them 20 ml per kg, followed by 3 ml per kg per hour. And in the moderate, they gave them almost half of the dose, which is 10 ml per kg, followed by 1.5 ml per kg. The primary outcome was the severity of the pancreatitis. What happened to this study, that this study was halted because of the safety concern. What is the safety that they found that there is fluid overload develops in 20% in the patient who receive aggressive resuscitation compared to 6.3% in those who with the moderate resuscitation. You can really see that this is the blue bar is the severe pancreatitis, and the orange one is the fluid overload. So in the severe, you can see the aggressive. If you give them severe fluid, the fluid overload is high. And when we talk about moderate fluid overload, you can see that the pancreatitis severity is the same, but the fluid overload is this. So this is another study confirming that we really have to be conservative on giving fluid to our patient. Another study looked at the liberal fluid in a patient with abdominal surgery, and they found that in the disability-free survival at 1 year, there was no difference. This study found that there is more of acute kidney injury in a patient who was on the restrictive, different from the previous trial. Now, this study was published a month ago, called the Classic Trial, published in the New England Journal of Medicine. This is compared, this is an open label randomized control trial in 31 ICU, and they compared a restrictive fluid to the standard fluid. The restrictive, they received around the median of around 1.8 liter, and the standard received around 3.8 liters. So there's a 2 liters difference between them. And they looked at the mortality and serious adverse effect and severe AKI. So what they found in this study that there is no difference between the restrictive and the liberal. So here is also another study confirming that restrictive fluid is as good as liberal. It doesn't really cause to any organ damage, and it does not really compromise survival. Now, we couldn't see a negative impact of the liberal fluid in the study, and this is one of the criticisms of the study, that there is only 2 liters fluid difference between the restrictive and the liberal. Maybe we would have seen a different side effect if the difference between these two groups is more than that. Now, high fluid balance increases the risk of death in a patient from sepsis, And this is, they looked at 1,800 patients with sepsis in 730 ICU, 84 countries. And patients were stratified according to the cumulative fluid balance 24 hours and 3 days after ICU admission. And here you can see that in the first day, there is no difference in the survival of those patients, whether you give them a lot of fluid or restrictive type of fluid. However, if you really look at after 3 days, you find that those patients who's receiving a low fluid or restricted fluid has a better survival than those patients who received a higher fluid. And then when they looked carefully into those patients, they found that those patients who died or who did not survive, they continued to have a positive balance at 3 days. But those patients who survived by 3 days, they're already EU balanced. So this is another study that's telling us that probably extra fluid in the patient after 3 days is contributing to their worse outcome. This is another study looked at the negative fluid balance. The blue is the patient who achieved negative fluid balance, and the red line is the patient who did not achieve. And this is the survival in 600 patients with septic shock in ICU. And again, you can see that those patients with a negative fluid balance has a better survival than a patient with a positive fluid balance. So how to manage our patient when he comes with in shock? So initially, the first phase is the rescue. So we have to be aggressive in resuscitation of the patient. And in the second phase, which is after hours, here's the patient is better. So we really have to give IV fluid as a maintenance. And after 12 or 24 hours here, we have to stop the IV fluid if there's really no need to give it. And after 72 hours, we really have to remove or try to remove this fluid by either diuresis or ultrafiltration if we cannot really remove this fluid. Now, we know that fluid overload is a risk factor for acute kidney injury. We know that the kidney is encapsulated organs. And whenever we have a lot of fluid, so it will put pressure in the venous system of the kidney, and it will decrease the renal perfusion. And that's why we see more of AKI with fluid overload. Now, this is a sub-analysis of the classic trial. Looked at those patients, even if you give them more fluid. So here, the standard care were the red bars, and the fluid restriction was the blue. And this is the first day after a randomization. And look at the urine output. So this is the resuscitation fluid. This is the fluid restriction, the blue, and the green is the standard. So what happened when you give them standard or restriction? The urine output was the same. So this is another message, is that even if you give fluid, you may not really even increase the urine output if you give an extra fluid. And surprisingly, that not only that, those patients who have worsening AKI favoring fluid restrictions. So those patients with fluid restrictions has a lower AKI or acute kidney injury than patients who are in standard care. Now, what about albumin when we select fluid? Is there any difference between albumin and saline? This is two landmark studies, one called the SAFE trial that compared albumin with saline, and you can really see that the survival is the same. So there's really no difference between albumin and crystalloid fluid in resuscitation. This is another study in 2014 also confirmed that whether you use crystalloid or albumin plus crystalloid, there is really no change or does not really improve. Adding albumin does not really improve the survival. In fact, we have to be careful on using the colloid solution like albumin in a patient with traumatic brain injury, because those patients, the probability of the survival in a patient with traumatic brain injury is better with saline than with albumin. So any patient with traumatic brain injury, we have to avoid the hypotonic crystalloid or the colloid solutions. Surviving sepsis campaign guidelines recommending that for adult with sepsis or septic shock, we recommend using crystalloid as a first-line fluid for resuscitation. So they're recommending crystalloid, not colloid. The other question that we always have to use and know, what should we use? Should we use the normal saline, or should we use a balanced crystalloid, which is ringer lactate or plasma-lyte? So those are two studies that looked into this. Is normal saline is better than ringer lactate, or is ringer lactate is better than normal saline, or are they equivalent? So those studies were published in 2018, and the first study has a 15,000 patients in 5 ICU, and they compared the balanced crystalloid, and here's like ringer lactate with saline. The primary outcome was the major adverse kidney event, and they reported that those patients who received balanced crystalloid like ringer lactate have a less kidney event than those patients who was saline. And that was a statistically significant result. In the other study, which again have a high number of the patients, but those patients from a single center, and they again compared balanced solution with saline, and the mean crystalloid volume was around 1 liter. And they also find that those patients with a balanced crystalloid, like a ringer lactate or plasma-lyte, has a less adverse kidney event than normal saline. So this is another study, confirmed the first study, that saline probably is increasing the risk of acute kidney injury, and probably we have to use a balanced solution during our resuscitation. Now, a few months ago, we have this trial, and they're called the PLUS trial, which has around 5,000 patients, and they compare those to they categorize, or they divided those patients to balanced solution to saline, and they looked at the death at 90 days, and they found that there's really no difference. We couldn't really see any difference between balanced and normal saline in this study, which was recently. Also, we did not really see any difference in the renal failure in those patients, normal saline or balanced solution. There is no difference in the survival, and no difference really in acute kidney injury. And this is another study which was published last year, called the BASICS. And in this study, they want to look what's the effect of balanced solution versus saline solution on 90-day mortality. And even this trial showed that there is no difference between saline and balanced solution when it comes to the survival. This trial has around 10,000 patients, and the primary outcome was the 90-day mortality, which was no difference. And also, they did not find any difference in the AKI or a kidney replacement therapy. One of the criticism of this trial is also that those patients were resuscitated initially before they really joined the study, and this could really contribute that to some of the result of the study, that they couldn't really find the difference. After that, we have this the evidence from the New England Journal of Medicine, and they took all these studies, 13 randomized controlled trials. They want to answer this question: did we use a balanced crystalloid or saline in critically ill patient? And they come with the conclusion that based on this, that it is in favor of used crystalloid. There is a negative and positive trials, but it is the result is in favor of using the balanced solution over the saline. Now, those are the trials. If you really want to compare the harm to the patient to the benefit, we know that starch or the colloid is harmful, so it's not really, we're not really using it. We know that gelatin is also harmful, and we know that from this SMART and SOL trial that saline is a harmful and balanced solution is beneficial. And we know that albumin has no difference. It's not harmful and it's not beneficial. It's as good as crystalloid type of fluid. So what the Surviving Sepsis campaign said that for adults with sepsis or septic shock, we suggest using a balanced crystalloid instead of normal saline for resuscitations. I would like to close with this slide, which summarizes all what I have said, that this is how we resuscitate the patient. And this is the U-curve that looked at the AKI risk in the patient with hypovolemia here and hypervolemia here. So when we resuscitate the patient with hypovolemia, we know that starch or colloid is harmful, gelatin is harmful. We know albumin as good as crystalloid. There is a superiority of the buffer crystalloid over normal saline. And if we really want to give fluid in this area, we need really to assess the volume of the patient. So we really have to use other measures to assess the volume so that we can give the volume based on the volume on the patient response. And if the patient has become hypervolemic, we really have to de-escalate and we really have to remove this extra fluid by loop diuretic or by ultrafiltration. Thank you very much, and I will be happy to receive any questions.
Thank you, Professor Lotfi. We have some few questions. How many hours to resuscitate and start maintenance in some cases?
Yeah, so this is based on the patient response. Now, as far as the patient is really in shock, then you really need to give fluids. However, you really, when you resuscitate with the 30 ml per kg, any extra fluid should really be only given after monitoring, because now the patient may need to be on a vasopressor, not fluid. So if he's still hypotensive after the initial resuscitation, he's probably maybe need more of a vasoconstrictor like norepinephrine than giving more fluid, because giving more fluid to those patients, you may push them into pulmonary edema and capillary leak and fluid overload. So we have to be careful after resuscitating the patient in the first 3 to 4 hours with the 30 ml per kg. Yeah.
I think this question you have answered already, like role of rising leg test and ultrasound to assess volume status.
Yeah, this is as I showed now. Unfortunately, we don't have a perfect tool to assess the volume in critically ill patients. So we're trying to use a multiple methods. And what has been shown is the straight leg test is really one of the easy and reversible that you can really do it in the ICU. However, we always try to avoid doing that test in a patient with increase in intra-abdominal pressure. So we really have to be careful if a patient has increase in the intra-abdominal pressure. But otherwise, it's a very sensitive and specific type of test that you can really do it. And if the stroke volume is increased by 10 to 15%, it means that this patient is volume responsive so that you can give him fluid. And if you did the straight leg raising test and the stroke volume did not really increase or increase by less than 10%, you know that this patient needs a vasoconstrictors, not fluid.
Okay.
The ultrasounds, yes, there's now a pocket or ultrasound, and is available in many hospitals, many emergencies. But again, this needs to be training, and it's operator dependent. But in good hands, it's a very helpful also in assessing the volume in the lungs, and the inferior vena cava, and the portal hepatic veins, and the intrarenals. So you really have to look at multiple areas to come to a conclusion. The good thing about the ultrasound, it can help you even if you try to de-escalate. You know, after you remove the fluid, you can repeat the ultrasound and you will see the difference in your assessment. Once you do it before you remove the fluid, and then repeat the ultrasound after you remove the fluid, and in good hands, it really showed a good result.
Okay, thank you, Dr. Lotfi. Thanks for being with us for the last few years since we started this webinar. and inshallah, we will have the honor of having you with us next year.
Thank you very much.
Please stop sharing. Dr. Ashraf, are you with us? Dr. Ashraf?
السلام عليكم.
وعليكم السلام دكتور أشرف.
الصوت واضح؟
تمام. We are very happy to announce for the presence of Professor Ashraf Hussein, a consultant in nephrology, head of nephrology department, Saudi German Hospital, Jeddah, and also he is a professor of internal medicine and nephrology in Al Mansoura University in Egypt. Dr. Ashraf will talk today about acute kidney disease. And I mean by disease, it is not injury and it is not end stage or chronic kidney disease. So thanks, Dr. Ashraf, for choosing this special topic. And we are delighted to hear from you about this.
Thank you, Dr. Ahmed, and thanks for your kind invitation. I hope, inshallah, my lecture will be informative just to put a spot in this new share screen.
From the green icon down, you can share the screen.
Okay.
I would like to take the opportunity to ask all the attendants for being with us for the last minute. And also some questions, we didn't have time to raise it with the professors and the presenters, and we will keep sending this question to them. And when they will answer, we will share it over the Q&A icon. Thank you. We can see your screen, Dr. Ashraf. Okay, full screen.
It's okay,
okay, everything is clear. Everything is clear. Everything is clear.
Okay. Bismillah ar-Rahman ar-Rahim. Today we speak about acute kidney disease. We know that KDP improving global guidelines address the definition, classification, and management of acute kidney injury, AKI, and chronic kidney disease since a long time. But in practice, some clinical presentation of the acute kidney disease and disorders don't meet the criteria for AKI or CKD. In the principle, this presentation may be caused by the same diseases that cause AKI or CKD, which could be detected, evaluated, and treated before they evolve to AKI or CKD. And the absence of an accepted definition and nomenclatures for this presentation represented a logical gap in the classification of kidney disease and disorders, and leave patient and the clinician without any management recommendation that could potentially improve the care and the outcome of the patient. And all we know that there is intersection between AKI and CKD, as we know the risk factor may be the same as age, race, genetic factors, hypertension, diabetes. And you know AKI can precede to CKD, and CKD can have in top AKI also. And the outcome mainly affect cardiovascular events and kidney events or end-stage renal disease, may lead to disability, diminished quality of life, even death. So KDIGO guidelines, AKI guidelines in 2011 suggest an operational definition of acute kidney disease designed to address the gap and to harmonize the criteria for the spectrum of the clinical presentation of AKI, AKD, and CKD, and also the absence of this presentation means no kidney disease or disorders. These guidelines considered of acute kidney disease as more heterogeneous group of disorders than AKI, and consider the AKI as a subset of AKD. And because of the absence of substantial evidence based on the epidemiology of the AKD, the academic guidelines didn't propose recommendation for classification or management till 2011. But in 2012, the academic guidelines AKI work group proposed the term of AKD to define any acute conditions that impact kidney function, including AKI, with specific criteria, means eGFR less than 60 milli per minute, or decrease eGFR for more than 35%, or an increase in serum creatinine of more than 50%, or any kidney damage lasting for less than 3 months. And the goal of this operational definition was to provide an integrated clinical approach to patients with acute abnormality of kidney function and structure, and help to unify the more established concept of AKI and CKD. And since this time, clinical practice guidelines for AKI first proposed the criteria for AKD. There have been 2 responses for these guidelines that specifically commented on the AKD concept. One from the National Kidney Foundation and other from the Canadian Society of Nephrology. The National Kidney Foundation expressed the concern that introduction of the terminology of AKD may cause confusion among physicians and other clinicians, and might adversely cause them to overlook other than important diagnostic consideration when evaluating a patient first presenting with kidney disease. They also express the concern that because of the broad range of unique conditions may be classified under the umbrella term of AKD, clinicians may label patients with AKD while failing to distinguish between the underlying etiology. Cadigo commentary suggested that a more in-depth evaluation was warranted about which specific kidney disease are likely to be captured under the AKD criteria, while they suggested that the term may be useful in epidemiology research or epidemiological research. This work group cautioned that it should not yet be used in clinical practice. And the commentary provided by the Canadian Society of Nephrology also highlighted that although the classification schema relevant to all patients with kidney disease was important and relevant to future research or further research, the clinical use of the term AKD criteria remained uncertain. Similar to KUK work group, the Canadian commentary highlighted that patients with severe underlying clinical syndromes, including rapid progressive glomerulonephritis, acute interstitial nephritis, atheroembolic disease, and urinary tract obstruction, may meet the AKD criteria. The opinion of this work group supports further epidemiological research based on the AKD concept, but cautioned against the clinical adoption for the concept at this time to avoid distraction from appropriate clinical investigation to identify the underlying causes of disease and the prompt treatment. And after that, in 2017, the Acute Dialysis Quality Initiative work group proposed a new definition for AKD to further refine this criteria, and also added a staging system for AKD. The report conceived of AKI as preceding AKD in most of cases. Usually our patient with AKI preceded AKD proposed a limitation for the duration of AKI to 7 days only. And if the patient continue, the terminology of the diagnosis will be changed from AKI to AKD after the 7 days, with persistent beyond this time as an AKD, and suggested a classification of AKD according to the preceding AKI stage. The update classification of AKD has 2 main features. First, it recognized an important population of patients which evolve in kidney disease who might not fulfill strict criteria for AKI or CKD, such as those with kidney disease, the onset of which is uncertain or subacute. Second, it highlighted that the process of AKD can include AKI and extend beyond mere detection or staging of the disease through the process of recovery or worsening until criteria for incident or worsening CKD are reached. So this figure shows that at the time of injury, if we can detect the onset of injury from 0 day to maximum 24 hours, this is the peak for AKI, and the most of hopeful outcome will be resolved with this period. If the injury continue till 7 days, still the patient has AKI. If continue after 7 days, but less than 90 days, it would be AKD. More than 90 days, it should be as a CKD. So the definition of AKD is defined as a condition in which AKI stage 1 or greater are defined by KDIGO guidelines is present for more than 7 days after an AKI initiating event. So AKD that persists beyond 90 days is considered as CKD. Recently in 2020, KDIGO guidelines conceived a consensus conference to review recent evidence of epidemiological of AKD and more fully discuss these topics. The consensus of the conference attendees was to return the KDIGO definition of AKD, recommended a classification of kidney disease consistent with KDIGO guidelines for AKD or CKD definitions, and they provided general recommendations on evaluation and management and outline research agenda. They propose that criteria for AKD include functional criteria for AKI or CKD, structural criteria for CKD of less than 3 months. Again, they put a definition, rising of serum creatinine for 50% or more from the baseline, or GFR decline for 35% or more from the baseline is included, and a 50% increase in a steady state serum creatinine from a baseline of 0.9 or more milligram per deciliter in men or 0.7 milligram per deciliter in women, corresponding to an approximately decrease in GFR by 35%. So a guideline definition of different AKI, we know that increased serum creatinine by more than 50% within 7 days, or increase in serum creatinine by 0.3 milligram in the first 2 days, and oliguria with the criteria we know it for AKD, AKI. And there is no different structural abnormalities present. CKD, GFR less than 60 milli per minute for more than 3 months, plus kidney damage for more than 3 months. AKD is our concern now, defined as AKI or GFR less than 60 milli per meter for less than 3 months, or a decrease in GFR by 35% or more, or increase in serum creatinine by more than 50% or for less than 3 months. And there is actually kidney damage for less than 3 months. Non-kidney disease, GFR more than 60 with no any structural damage for less than 3 months. For table 2, we show a recommendation for AKD staging. This is the final recommendation. Stage 0, absence. Stage 0 subdivided into A, B, and C. Stage 0A means absence of B and C. Stage 0P means continued evidence of ongoing injury, repair, or regeneration, or indicator of loss of renal, glomerular, or tubular reserve. Stage 0C, serum creatinine level is less than 1.5 times the baseline, but not back to the basal level. Stage B and C is serum creatinine of less than 1.5 times the baseline, but not back to the baseline level, and continue evidence of ongoing injury, repair, and or regeneration. Stage 1, serum creatinine level from 1.5 to 1.9 times the baseline. Stage 2, serum creatinine level from 2 to 0.9 times the baseline. Stage 3, serum creatinine level 3 times baseline, or increase in serum creatinine level more than 4 milligram per deciliter, and or ongoing need for renal replacement therapy. This is the classification of AKD. As regards the causes of AKD, classification of AKD, like AKI and CKD, include causes of the disease, which direct cause specific treatment, cause of AKD are generally the same as for AKI, but without or before sufficient GFR decline to fulfill criteria of AKI. Or the same, and we will use the criteria for classification of AKI in this type. The same as for CKD also, but without sufficient duration to fulfill criteria of CKD. So for example, of our etiology, decrease of kidney perfusion, volume depletion, heart failure, cirrhosis, segmental, arterial or venous infarction, parenchymatous kidney disease like acute glomerulonephritis, new onset nephrotic syndrome, pyelonephritis, interstitial nephritis, papillary necrosis, thrombotic microangiopathy or microangiopathy, and mild acute tubular necrosis and or obstructive or urinary system, especially if unilateral. But irrespective to the cause, further classification of AKD is based on the severity or staging, which directs stage-specific treatment. Usually AKI received by AKD with AKI would be classified according to the AKI stage 1, stage 3, and defined by the severity of oliguria or serum creatinine increase. Whereas AKD without AKI or not preceding the AKI would be classified according to the level of GFR and microalbuminuria corresponding to G and E categories for CKD. Following resolution of AKI, the resistance of AKD would represent AKD after AKI. Classification of AKD after AKI may be difficult because it's challenging to estimate the GFR when serum creatinine or the extracellular fluid volume is not in the steady state. I mean that still the disease is progressing. It would be reasonable to classify AKD after AKI according to AKI stages when in the steady state, whereas AKD without AKI can be classified according to G and E categories when it's in the steady state. And alternatively, a kinetic estimated GFR equation could be used in the non-steady state. And this figure shows a conceptual model for the overlap between AKI, AKD, and CKD. We see that AKD now is a broad term, including inside AKI and overlap with CKD. So to improve AKI within 7 days, onset of the disease with increased serum creatinine more than 50% within 7 days, or increase the serum creatinine by more than 0.3 milligram deciliter within 2 days, and oliguria more than 4 hours. But AKD is less than more than 7 days and less than 3 months. AKI or GFR less than 60 milli per minute, or decrease in GFR by more than 35% times the basal line, or increase in creatinine, as we said before, more than 50% from the basal line. But here, there is a marker of kidney damage, mainly albuminuria, hematuria, pyuria are most common. CKD, of course, duration more than 3 months, GFR less than 60, and is a marker of kidney damage, mainly albuminuria. Non-kidney disease, this GFR more than 60, and no marker of kidney damage. This acute dialysis is quality initiative definition of AKD and recovery from AKD. Acute kidney disease decreases acute or subacute damage or loss of kidney function for duration of between 7 days and 90 days after exposure to an acute kidney injury initiating event. Outcome of AKD include recovery, recurrence of AKI, or progression of AKD and or death. AKDs that persist beyond 9 days should be considered as a chronic kidney disease. For the recovery from AKD can be defined as reduction in the peak of AKI stages, or return to renal reserve again. And for the long-term outcome among patients with AKD are not represented or determined carefully and might be influenced by the care duration during the transition from the acute care setting. And the care of patients with AKD after hospital discharge is inadequately characterized. Limited observation data suggested that survivors of the AKI will be cared for by a diverse group or provider with some patients not receiving timely assessment of kidney function, ongoing kidney damage, or associated complication. So acute kidney injury is a risk factor for the future loss of kidney function, cardiovascular disease, and death. Defining optimal follow-up care for this high-risk population is therefore essential, especially during the transition of care beyond the acute care setting, when recovery from AKI and its underlying precipitating might be ongoing. An AKI initiating event can usually be identified but not required to diagnose as AKD. Now, if we go for the typical scenario in which patient may present with AKD, including conditions in which AKI is observed and the patient remains in KD stage 1 or greater for more than 7 days. This is one condition. Another one in which an episode of AKI was not observed. Okay, for example, patient with community-acquired AKI, but inferred by the persistence of kidney disease beyond 7 days for patient without a known baseline of creat value or clinical justification of AKD versus CKD might be required. Another condition patient in which subacute AKI documented by either histology or imaging or probing biomarker or a relevant exposure such as to nephrotoxic doesn't meet criteria for diagnosis of AKI or CKD, so is a case of AKD. Lastly, in which AKI is observed, partially improved, and then progressed after 7 days as AKD, not AKI. Here we show for the approach for follow-up patient, as we said, a patient based in the stage 1, AKD, patient education, medication reconciliation, and nephrotoxic avoidance. Stage 2 need more and more frequent follow-up for marker of injury or marker of repair. Stage 3 AKD need nephrology, referral, and follow-up. Here, if patient with AKI and during the AKI in the early 7 days need replacement therapy, they will continue as AKD, ongoing renal replacement therapy. And if it's create for 3 times with renal replacement therapy, the same staging will be in AKD. Create doubling will be the same. I mean that the patient will take the classification of staging based in the previous AKI. If they continue beyond the 90 days, it will be as a CKD. So we have now a recommendation for the assessment of recovery in patient with renal replacement dependent AKD. First of all, renal recovery in patients with acute kidney injury who are treated with acute renal replacement therapy is defined as a sustained more than 14 days independence from CRRT. Second, current tools and diagnostics are insufficient to accurately assess the kidney function in a patient receiving acute CRRT. Third one, limited data exists on how to use clinical factors and diagnostic tests to reliably predict non-recovery among patients with acute kidney injury on CRRT. Last one, insufficient data also are available to recommend a specific CRRT technique to improve renal and patient recovery. Finally, insufficient data exists, no recommended specific process of care or technique to improve renal and patient recovery for patients with CRRT-dependent AKD. So, this need for this further limitation for the current AKI and CKD definitions and classification system arises from the fact that there are patients who present with alternation of kidney function and structures that don't meet the established criteria for AKD or CKD. And this is not surprising because the definitions and the classification of system were developed by different groups focusing on different clinical syndromes. On the other hand, abnormalities of the kidney disease markers that don't meet existing definitions for AKD and CKD still require medical attention to avoid adverse outcome. For these reasons, the AKD and clinical practice guidelines and AKI guidelines work group proposed an operational definition again for acute kidney disease and staging. So the definition, the classification of acute kidney disease continue to evolve. New criteria proposed for AKI or AKD, sorry, attempt to provide a comprehensive nomenclatures for the kidney disease encompassing those disorders that don't meet the criteria for AKI or CKD, but may still require medical evaluation and treatment. While it may be premature to adopt these criteria into clinical practice, preliminary evidence support the hypothesis that AKD criteria identify patients with varied histological kidney disease of clinical importance. So as we said, there is a gap and there is lack of knowledge, there is no clear recommendation. So knowledge gap and future research or direction for AKD for recognition, this characterization of incidence of AKD across various settings, may be hospital or acquired, community acquired, emergency, including those not fulfill AKI or CKD. This is an area for research, future research. And AKD management still need examination of process of care for those presenting with AKD criteria, including how patients with AKD without AKI or CKD are investigated and managed in clinical practice is still point for research. And the prognosis also for AKD, population-based studies to examine incidence and the progression of key outcomes such as CKD or end-stage renal disease or mortality still in need. Plus AKD in relation to CKD and AKI, research to better characterize the features of AKD associated with progression of CKD rather than recovery or subsequent normalization of kidney function, including a better understanding of influence of variability of kidney disease. Clinical impact of case finding, evaluation of clinical implication and the cost strategy for case identification and the clinical surveillance of those with AKD, including evaluation of clinical impact of introducing AKD definition into case finding and referral practice. Application of classification system and models of care encompassing CKD and AKD, determine whether education, dissemination, and implementation strategy for applying the AKD criteria in conjunction with models of care that encompass both chronic and acute disorders improve short and long-term clinical outcomes. All these are areas for future research and investigations. But for a while, we can just consider some consideration about nephrotoxic and how to manage patients with AKD and nephrotoxic. It's not different from AKD and CKD. And when to avoid starting nephrotoxins, patient with no risk of factors for kidney injury as the risk factor, diabetes, hypertension, old age, proteinuria, hypertension is suitable. And the less nephrotoxic drug is available, it's better. Nephrotoxins is considered non-essential, so we can avoid it. The patient is already receiving a nephrotoxic drug and concern exists regarding the pharmacodynamic or kinetics of drug interaction. Intended duration of the drug therapy in chronic and initiating the drug can be delayed until after the acute kidney disease episode has resolved. Concern exists for the lack of appropriate follow-up of serum creatinine level and therapeutic drug concentration monitoring. This is a problem. But now I think if a hospital has a clinical pharmacist, which can perfectly adjust the dose for the kidney condition. But when to discontinue nephrotoxins in patients with AKD, an evaluation of the causal relationship between that nephrotoxic is a potential cause of AKD or AKI, so we can stop. A suitable or less the nephrotoxic drug available we can use. The nephrotoxins is considered non-essential. Okay, last one. Other consideration for nephrotoxins management, regular monitoring of the functional status while on a nephrotoxic is needed. The duration and dose of nephrotoxic exposure should be minimized if possible. Evidence-based dosing guidelines should be followed. This is all for AKD, so we can go for just to take home message. In AKD is defined as a condition in which the AKI stage 1 or greater, as defined by clinical guidelines, for more than persistent for more than 7 days after an AKI initiating event, or AKD that persists beyond 9 days is considered as a CKD. Proposed criteria for AKD including functional criteria for AKI or CKD, or structural criteria for CKD for less than 3 months. KDIGO guidelines in 2020 both classification for AKD. Acute kidney disease is a risk factor for the future loss of kidney function and cardiovascular disease and death. Defining optimal follow-up care for the high-risk population is therefore essential. Current knowledge gap and the future research needed to inform the adoption of the AKD criteria in clinical practice. The AKD criteria could be useful for research on recognition, management, and outcomes of patients who present with new evidence of kidney disease across a variety of clinical settings, including community, emergency department, and hospital, when additional information from serial measurement of kidney function are lacking. Conceptual approach based on AKD criteria might help consolidate research effort to characterize the bidirectional relationship between CKD and AKI. Future research is needed for better understanding the clinical characteristics, population-based incidence, and prognosis of AKD. And thank you.
Thank you, Dr. Ashraf, for this nice presentation. We have only one question about use of RAS blocker and SGLT2 inhibitors in AKD.
Actually, there is no any research in this area, but most of RAS inhibitors and SGLT2 inhibitors, all data came from CKD, not from AKI or from AKD. So actually, there is no answer, actually, honestly, no any trials for using SGLT2 inhibitors or RAS inhibitors in AKD. This should be individualized based in the patient condition, based in the etiology itself for the AKD or AKI. This is my opinion, but there is no research, as no recommendation, no guidelines for this, all for the CKD only.
Okay, thank you, Dr. Ashraf. And, thanks for giving us this honor, and please stop sharing your screen. And now we are happy to announce for presence of Dr. Mireille Karavetian. Dr. Mireille, I have known her a few years ago. She's specialized in renal nutrition. That's why we make session for kidney diseases and nephrology. We cannot miss presence of Dr. Mireille. Dr. Mireille is a graduate of American University in Beirut, worked in United Arab Emirates and also in Canada. She is a clinical nutritionist and specialized in kidney diseases. She had a PhD from Maastricht University and currently working as lecturer in Ryerson University in Toronto, Canada. Thanks, Dr. Mireille, for being with us.
Thank you. Thank you for having me, and thank you for allowing me to join this reputable conference. Sorry, just 1 second for the camera.
Take your time.
Yes, okay. This is fine, right? Okay. So today I will be talking about nutrition support and a little bit more on the liberalization of nutrition restrictions that we keep on giving to these patients. Okay, sorry for the camera, it's a bit hot. Okay, thank you for the introduction, Dr. Ahmad. I will, with no further ado, I will start with my lecture. And I hope it can leave an impact and maybe change the daily practice of the practitioners listening to it.
Sure, we are sure that you always change our mind regarding nutrition, especially in kidney diseases. We as nephrologists, we used to tell the patient what not to eat. Don't eat like this, don't eat like that. But from your side, we learn before how to tell them what to eat and how to give alternative. And this is what we are expecting to hear from you.
Yes, today I will tell more to eat, actually. So,
okay.
So the prevalence of chronic kidney disease has increased dramatically over the past 2 decades. not just around the world, but also in the Gulf countries. In the Gulf countries, around 4.6 males and 2.8 females have kidney disease. These are some of the risk factors that increase the chances of a person having CKD. Age, progressing age above 50. Now, obviously, they're a combination. Not everybody who's above 50 is in risk of CKD. Coronary heart disease, diabetes, hypertension, smoking. Now, a quick thing that I always encourage clinicians to do is to have every obese, every hypertensive, and every diabetic every 6 months do a urine dipstick check to see if there is microalbuminuria or macroalbuminuria within their urine, because that can help actually increase the screening for potential early on kidney disease patients. And it is a very cost-effective tool. And I would hope that not just physicians, but also pharmacists, dietitians, whoever is available for the patient, to actually remind and have it within their routine care. As I said, the high-risk ones from the earlier one from the earlier slide that we saw, cardiac, hypertensive, diabetes, and obese patients, they're all in risk for having eventually CKD. Now, the CKD, as you all know, is a result of these 3 diseases. I will not go into that because I want to use the time for something new. Malnutrition is extremely prevalent among these patients worldwide and in the Gulf. Around 40% of patients in the world, hemodialysis patients, are malnourished. Protein energy malnutrition is very prevalent. If you can see here, 18 to 75% of dialysis patients, 75, that's almost all, patients have protein energy malnutrition, and albumin is quite low. Now, I don't depend so much on albumin because, as you know, albumin is also an inflammatory marker. That is why we have other methods to analyze protein energy malnutrition, which I will share a bit later. Now, also this I would like to share is that as the kidney disease advances, the more there will be a chance for malnutrition and protein energy malnutrition. As you can see, stage 1 to stage 5, and the arrow goes up and reaches to 75%. The more nephrotoxicity there is, the more inflammation there is, the more the person doesn't feel like eating, has a low appetite, and this will lead to more and more risk of protein energy wasting. And protein energy wasting, why are we so afraid about it? Why is it that we care about it? Now, a little bit more about the prevalence. Around 30 to 45% of patients from recent studies in the last decade have shown that dialysis patients are malnourished. Now, is there a role for oral nutrition supplements? What to do, how to fix this? A little bit more on the frequency. When analysis was done for the amount of protein consumed by dialysis patients, most were eating around 1 gram, and yet you know that in dialysis we say at least KDOQI guidelines says at least 1.2 gram per kilo. So it is not that we are as clinicians restricting, but patients are also eating less. And one of the main reasons is that because very often they're very confused on what to eat, so they end up eating little of everything to make sure that they do not surpass their needs. But that also leads to protein energy wasting. Now, MIS, something that is very close to my heart, is called malnutrition inflammation complex, where dialysis or renal failure patients, the more overweight they are, the more safer they are than the lower weight ones. Why? Because, as you know, kidney failure is a highly inflammatory disease. And when inflammation is high, appetite drops. And this doesn't help with the intake of food. Now, MIS, malnutrition inflammation score, is a mix of objective and subjective tools, and easily to be used within a practical setting. It is a complex tool, but it takes, I think, maximum 3 minutes to actually conduct it. Now, MIS showed that as the MIS increased, meaning the risk of malnutrition increased, the hazard risk of all-cause mortality increased among hemodialysis patients, which one more time says that it is really worth to invest time and effort in malnutrition management. As you can see the curve. And yes, it's the same here. I will go on. And I actually, sorry, I want to go back to the slide. On the right side, it says that the ratio is 1-to-1, meaning as the malnutrition inflammation score increased, the proportion of survival decreased equally. It was almost a direct causality. Why do we care about patients' nutrition? Because as you see here in the BMI, again with the all-cause mortality, as BMI decreases, and here you see the graph is going to the left, all-cause mortality increases. As the BMI increases, all-cause mortality decreases. So only within the case of these patients, we would say that a little bit being more overweight is kind of a little bit safer than being underweight. And you can see here kind of the middle. I don't know if you can see my arrow, but the middle is 25 to 27 BMI, right? I will come back to that number later on. Another one to assure that you do believe that malnutrition is important is the percent change in body weight. Now, this word is a fantastic key word because you may see a patient who is, let's say, 100 kilos, and you might consider that this patient is well nourished and they do not have undernourishment, and immediately you would consider a patient who's 45 kilos, a malnourished one, and you would see how to solve that. But a 100-kilo person you might overlook. A very key question is, have you been in the same weight, or have you involuntarily lost weight recently? And if they say that yes, let's say you find out that this patient a month ago was 120 kilos and involuntarily became 100, that patient becomes more at risk than the other one who is 45 kilos and has been 45 the past 3 years. Okay, so here this is a window of opportunity to identify who needs us most and who needs to be taken care of. So percent change in body weight. Also, if there is a radical percent change, especially if it's above 10%, and this is where we call it significant weight loss, 10% and more, and you see on the right side of this curve, 10%, 20%, 30%, and the mortality hazard ratio is increasing highly. Now, what is malnutrition? Malnutrition in dialysis or in renal failure patients is very complex, is a result of many components. One of them, I'm going to try to find my pointer. Yes, you can see now my mouse. So I'm going to try to guide you through it. For obviously, we have inflammation because of the renal disease. We have uremic toxins, which do not help. We have hypercatabolism. I don't think I need to explain a little more on that, but I want to go back on these. Nutrient intake, prescribed dietary restrictions. You know very well that we tell patients a whole list of what not to eat, and very often the patient feels overwhelmed, feels like, oh, what will I eat? And they feel more confused. There is a volume overload. They might drink a little bit more and have a volume overload, and that would suppress on the stomach and the diaphragm and feel like they don't feel like eating a little bit more. Oxidative stress, production of inflammatory cytokines, comorbidities that cause even more restrictions, like, for example, diabetes or aging. They may not be able to chew food as comfortably as they want, and insulin issues, which causes lack of proper efficient metabolism of carbohydrate, nutrient losses in dialysis. You know very well that each session of dialysis loses around 0.4 gram per kilo body weight of protein, and the whole effort of going and coming to dialysis and feeling tired, that would miss out on a few hours of eating normally. Now, all of these factors end up resulting in low albumin, high CRP, low weight, decreased weight, BMI, sarcopenia, which is a loss of muscle mass to a significant level that causes disease state. Survival paradoxes, people will have less survival chance if they are so low in weight. Mortality, hospitalization will increase, quality of life will decrease. So you see, it is a very complex issue. And in the middle of it, what is it? Protein energy wasting and cachexia, which is why I keep on coming back to this word, protein energy wasting. Now, eating or oral nutrition supplementation should be encouraged during hemodialysis. This is something that came out a few years ago. Now, let's see another article that came out recently. Let them eat during dialysis, an overlooked opportunity to improve outcomes in maintenance hemodialysis patients. And I'm sure many of you know the author Klantarzadeh. He is one of the main authors and writers of the guidance for renal management. Another one came out, eating during treatment can be cost-effective way to improve outcome. Another one, rethinking the restrictions of nutrition during hemodialysis treatment. So you see another one, dietary restrictions in dialysis patient. Is there anything left to eat? So more and more publications are coming out, inviting people to reconsider the guidelines that we had, inviting people to reconsider, are we doing the right thing when we are restricting so much to these patients? Now, the pros and cons of increasing food during hemodialysis and increasing just liberalizing food. If we do that, there is reduced mortality, improved nutritional status, patients' adherence and satisfaction to the diet and dialysis, all in all, education opportunity, because if you serve as a tray to the patient what is the allowed food within the dialysis session, and then that would be a good way for them to actually see what is allowed and how they can have proper meals at home, how they can use these dietary restrictions to cook the meals that they like and they can share with their family. And that way they can actually abide by the diet more, provide more appropriate food choices and reduced inflammation. Now, obviously, on the other side, if they're eating during dialysis, there might be some chances of hypotension, increased staff burden, financial constraints, and sometimes aspiration because they're lying down. But then again, these are things that can be fixed. Effect of eating during treatment, nutritional status, what happens is it increases protein content in the body, increases dietary intake. These patients start meeting their dietary needs. Serum albumin improves, nutritional status improves, net protein balance improves, and subjective global assessment, which is like the MIS that I discussed earlier. It is a global assessment of many factors that shows if the patient is malnourished or not. Now look at this. I want to first introduce these words. IDPN is interdialytic parenteral nutrition. ONS is oral nutritional supplement. So it could be like these supplement drinks that are ready-made shakes that could be given to the patient. Now look at this. These are patients before hemodialysis, during hemodialysis, control patients. What happened to their protein? These one decreased because they didn't eat anything during dialysis. The IDPN one, interdialytic parenteral nutrition ones, had a very high increase in their nutritional status, and ONS, oral nutrition supplement, did the same. Now, after hemodialysis, oral nutrition supplement kept a longer effect. And this is why, I'm a high advocate for interdialytic parenteral nutrition, but when it comes to effectiveness, studies have shown that ONS is more cost-effective than IDPN. That doesn't say that some patients will not need IDPN, but the first line of action, if food is not sufficient, can be ONS. Now, another thing that before I go on a little bit more on the guidelines, how to manage this, is to identify a few givens. BMI for dialysis or CKD patients is not, normal BMI is not 20 to 25. It is 22 to 27. This allows a little bit safety. You remember I said that a little bit, if they're more overweight, they have safety cushion to fall on to prevent them from falling into malnutrition. And here comes the same thing, that BMI 20 to 27 is the normal for CKD or hemodialysis patients. And energy should be given somewhere between 25 to 35 kilocalories per kilo, depending on BMI, which means if they're underweight, you will give the higher calories. If they're overweight, you will give them the lower calories per kilo. Now, how do we understand what is their ideal body weight? Ideal body weight should be completely removed, and it's been almost a decade that standard body weight is advocated for these patients. And this is a table how to find out standard body weight. Very quickly, I will say an example. Basically, you need frame size, height, and age for the patient and their gender. And for this patient, a female who is somewhere between 25 to 54 years old, 165 centimeter, and medium frame size, then her standard body weight is 63. So this is the weight that you will be using to calculate the person's needs, which means that we will not use any more ideal body weight. We will use standard body weight. Why? Because I just said that the normal BMI for these patients is a little bit higher than the regular population. So ideal body weight that is made for the regular population should not be used for dialysis patients. It should be different ones should be used. So new BMI and new ideal body weight calculation. Now, this is the slide that I want you to concentrate with me, and I'm going to try to remove the bar of the Zoom so that you're not it's not blocking the way. So prevention, and I'm going to go as slow as possible, so because this is a very key slide on how to manage this whole thing. Periodic nutritional screening should be done and nutritional assessment if needed. Now, after that, the first line of action has to be continuous preventive measures, continuous nutritional counseling through the dietitian, optimize the renal replacement therapy with the medical team so that dietary nutrient intake is improved, and manage comorbidities. Now, this is quite often this is done, but after this, very often the care doesn't continue, and I would invite people to actually consider their practice. Now, here comes implications for nutritional intervention despite preventive measures. So we did the preventive and did not work, and the patient still has malnutrition. How do we identify? Poor appetite or poor oral intake. So these are like assessment or screening tools. Does the patient have dietary protein intake? DPI is dietary protein intake less than 1.2 gram per kilo. Remember, we said for dialysis patients, they need to eat at least 1.2. And DEI is daily energy intake. So are they taking a low calorie diet and a low protein diet? If yes, then there is also a marker that the patient is heading to malnutrition. Albumin is here, but I don't like to depend so much on it, as I said earlier, because it's also an inflammatory marker. Unintentional weight loss, 5% within the past 3 months. Worsening of nutritional markers. SGA, standard subjective global assessment, or if you have MIS, malnutrition inflammation complex, as tools to analyze protein energy wasting. So these are all ways, and any one of them is good enough. You don't have to do all of them, just one of them is good enough. So see within your practice what is the best way and identify and just implement. You may actually say, you know what, poor appetite and poor oral intake and low energy intake is more than enough for me, or even more easier for especially the physicians. I think the unintentional weight loss is easy because you can always look into the patient's chart in the dialysis, or if it's a pre-dialysis patient, you can ask them, have you lost unintentional weight very recently? And that would be good enough. And once we go ahead, the start of CKD specific oral nutrition supplementation is needed. CKD, if the patient is not yet on dialysis, then the dietary protein intake target should be at least 0.8. But if the patient is on dialysis, then the patient should be at least 1.2 gram per kilo. Now, if there is no improvement or albumin is still low, then this is what we need to do. Maintenance of nutritional therapy goals. Intensive therapy later on, and this is what I'm going to focus on a bit later. You're not seeing my mouse still. I'm really sorry for that. Okay. So maintenance of nutritional therapy goals, if albumin is more than 4, then great. If pre-albumin is more than 30, if DPI, dietary protein intake, is more than 1.2, and if dietary intake is more than 30 to 35 kilocalories. If you've achieved these, then great. Then you stop your intervention, you say, you know what, I did my job. But if that is not available, then you go to an intensive therapy. And intensive therapy is dialysis prescription alterations. You might consider instead of 3 times a week, maybe every day, 2 hours. I don't know if that is practical. I will not intervene in that. I'm a dietitian. I will stay within my scope of practice. Increase quantity and oral therapy, quantity and oral therapy, meaning try to identify what is the person eating. If they're not having ability to eat through food all their needs, then oral nutrition supplement should come in hand. Tube feeding if the patient is not at all able to swallow, and even parenteral nutrition, interdialytic parenteral nutrition, or total parenteral nutrition if needed. Now, adjunct to these, if these are not helping the patient gain weight, another thing would come, which is, again, needs more maybe an endocrinologist or the physician to help out anabolic hormones, androgens, appetite stimulants. I don't know if you know, there is this medication called Megase or megasterol acetate, which is used for cancer patients, but there is no inhibition to use it in anyone else, in any other patient who has appetite issues. And it is just a regular pill with very low side effects. And it doesn't have, it's not an injection. It's literally a pill that can be taken. Again, I want to repeat the word Megase or megasterol acetate. So these are the names, generic names that the medication is used. It's an appetite stimulant, anti-inflammatory interventions, omega-3, exercise as tolerated, and I'll talk about exercise a bit later. So you see, all of these will help out with tools to help the body become more into the anabolic side and not the catabolic. Sorry. Okay, so I'm going to go back, take the bar up. Now, the pros and cons of eating during dialysis are equal. As you see, I will not read all this, but definitely there's a lot, but basically they lie on the same factor that I said earlier, which is the pros are the patient becomes better, acquires a better nutritional status. The cons, there is a risk of hypotension and aspiration, the burden on the dialysis staff, and it's a cost to provide the food. But I believe that when we look at it, all healthcare professionals are there to improve the health of the patient, no matter what. And I think the pros, if you read them carefully, will outweigh the cons. So protein and mortality type. Higher proportion of protein from plant sources is associated with lower mortality. Now, we know this for all the other populations, right? But with dialysis patients, what is the first thing that comes to your mind when you think of this? Potassium, right? We restrict potassium, so which makes it a little bit complicated to increase protein sources from plant sources. But we know that in every population, we keep on saying that increase your plant sources because they will help you decrease inflammation and increase mortality. But with these patients, what do we say? We say cut down your vegetables and fruits because they are high in potassium. So there is really something to reconsider. Healthy dietary patterns were consistently associated with lower mortality, and this comes from a decade of meta-analysis. Meta-analysis is all types, every meta-analysis article compiles all the articles that have published throughout that maybe decade or more within the topic, and find out results from that. And a total of 15,000, almost 300 patients from 7 meta-analysis comes out with this result: healthy dietary patterns. Now, we do not tell dialysis patients to eat healthy. We tell them low fruit, low vegetable, high protein, animal protein, right? And the whole world, every single patient other than dialysis is actually told the opposite. So again, are we doing the right thing? fruits and vegetables, it shows here that dialysis patients do not eat enough fruits. I will just go directly to the conclusion. Fruits and vegetables intake in dialysis patients is low, and a higher consumption is associated with a lower all-cause non-cardiovascular deaths. So we really have to improve. We cannot think that, it's always in healthcare, it is, you have to weigh your words and see what is the best for the client. So we come back to let them eat healthy. Now, let them eat healthy comes with the idea that maybe we should use potassium binders as routinely as phosphorus binders are used. We are very used to the idea of phosphorus binders, but what about potassium binders? I believe that this is the part where maybe physicians can start thinking of changing their practice. And again, Kalamtarzadeh is an advocate in this. Now, the idea is let them eat more liberally and use potassium binders. Now I'm going to go back more into it. Potassium binders. Now, what do we use to use? Usually, potassium is managed with dietary potassium restriction, potassium excreting diuretics, eliminating renin-angiotensin-aldosterone system blockers, and potassium binders. But the potassium binders are like K-oxalate, and they cause diarrhea and GI distress, right? Now, there are 2 new binders that have come out in the US, and they are powder-based, and they can be mixed in the food, just like phosphorus binders, right? Phosphate binders, what do? We ask the patient to take them with the food, and it chelates phosphorus from the food, doesn't allow the phosphorus to go in. The patient improves their dietary intake, eats proteins, less the phosphorus. So the same thing, the same concept now is being advocated for potassium. These are the 2 types of potassium: sodium zirconium, silosilate, and patromer. So these are the generic names of the potassium binders that have been advocated, and they are powder-based. They can be used in the food. Just one thing, which is in the red, I've highlighted, due to potential drug-binder interaction, it is recommended to separate the binder from drugs by 3 hours. But the same thing with it for phosphate binders, right? There is no news there. So this is a sample of a diet, a potassium limited diet, and then a liberalized diet. Now let's look into it, because you can see that the patient here will eat more. Look at this: sugar-free maple syrup, unsweetened grape juice. In return, here comes strawberries, blueberries, grapes, and walnuts. Now look at these. The last part, again, my mouse is gone. So the last part, these strawberries, blueberries, grapes, and walnuts. What are these? These are a bundle of antioxidants, and these patients are in dire need for antioxidants. They have high inflammation, which they really need. Here comes hummus. Look at this. Hummus is very high potassium and phosphorus. We don't give these patients hummus, but hummus is a plant source of protein, and a very healthy one, and filled with antioxidants. But when we end up giving these patients phosphate and potassium binders, then they can actually enjoy green beans and so forth. I hope the idea is clear. So practical implication: ingestion of potassium-rich foods is beneficial, as it reduces the incidence of stroke, hypertension, nephrolithitis, kidney stones, and osteoporosis. Currently, patients who would most benefit from increasing their intake of potassium-rich foods are the very patients who are unable to do so because of reduction in kidney function. Therapy to reduce hypertension and provide cardiorenal protection is often suboptimally dosed due to the risk of hyperkalemia. We are so afraid of hyperkalemia that we restrict these patients from eating their proper antioxidants. Now, when dietitians were told that, would you be comfortable to liberalize your diet, they were moderately comfortable. When patients were told, would you be happy to liberalize their diet, they were perfectly happy. Now, so a stepwise guide for how to manage the interdialytic nutrition is first food, regular healthy food during dialysis and outside of dialysis. Protein, if that doesn't work and that is not sufficient, then protein-rich or energy-rich snacks. It could be bars or shakes. And if that doesn't happen, then oral nutrition supplements, which are meal replacement shakes. And if that doesn't work again, then we go to IV, interdialytic parenteral nutrition. And if that doesn't work, then IV albumin might be needed. But again, I mean, this should be the last resort, and usually these end up helping. Interdialytic weight change. I can skip this. Now, do not forget the water-soluble vitamins that these patients need to take, but I don't think that is something that people forget because we know that dialysis, what it does to water-soluble vitamins. And last but not least, interdialytic exercise. Again, the Zoom bar I will remove so that you see. And interdialytic exercise, I've conducted a study like this in UAE in a hospital. Maybe one of the physicians is here, I'm not sure. And what we did is exactly like this. We put pedals on dialysis patients, and during their 4-hour dialysis, they were asked to exercise for 45 minutes with a minimum of 20-minute intervals. So 20 minutes, rest, 20 minutes. Now their heart rate and blood pressure was monitored to make sure that there was no issues, so that their intensity of exercise was standardized for each patient, which was a safe exercise limit for that patient. Now, when we did this, you know what happened? Patients' phosphorus clearance improved during dialysis. Their longevity improved. They had less depression. Their URR, the adequacy of dialysis improved. And they started having better nutritional status and better quality of life. So definitely worth to, and it is very cost effective. I think the machines that we used were, every one of them was, I think, around $100. And, you have 25 beds maximum. So 25 times 100, that's all you need. And just you need to put them next to the beds, and when the patient comes, just ask them to use it for 45 minutes. Of course, not every patient will be eligible. There was around like 10% of patients that were not allowed to exercise according to the physician, but most were able to exercise. So definitely worth investing time and effort into this. Now, this is a very jammed slide, but this is all the recommendations for all the kidney stages for renal failure, their nutritional needs, protein, energy, sodium, potassium, irrelevant if there is potassium binder, yes or not. And the same thing goes for phosphorus, calcium, fluid. I will not go into detail of this because this is kind of a little bit outside of the scope, but this also tells you how complicated their diet is. And very often dietitians and physicians are confused on how to prescribe this diet. So you can imagine how confused the patient will be. And this is why, one more time, liberalizing the diet is something to work on. Is medical nutrition therapy effective? Well, look at this. 2 hours per month of dietitian counseling the patients showed that it improved the health of the patients and improved their longevity by at least 12 months. So yet another thing to invest on, having dietitians be fully trained, dietitians be fully available in the dialysis. And this is the role of the dietitian in the nephrology field. She or he has a lot of roles, and they're quite intense and very complex. And it is not just looking into the potassium and phosphorus levels, accordingly counseling, but also helping in general, help the patient achieve a satisfaction from their food while maintaining their restrictions, while allowing them to not have protein energy wasting. So there's a huge balance that needs to be done. These are my references, and I hope you enjoyed your my lecture. And if you have any questions, I'm here. Thank you.
Dr. Mireille, thanks for this nice presentation. We always expect that renal nutrition is easy, but it is really a complicated subspecialty, and it needs someone like you to present a nice presentation like this. I will have 1 or 2 questions for the time factor. One of the questions I think we have discussed it before about AKI as a hypercatabolic state. What about protein diet in AKI?
Now, acute kidney injury is, as the name is, acute. So it is not long-term to have a long-term effect. So during that time, because it is a huge insult on the body, it's a huge trauma, within that time frame, a maximum of 1 gram per kilo, and that is a maximum of 1 gram per kilo of protein should be given. Usually should be around 0.6, 0.7. 1 gram may be allowed if the patient has a very low albumin of 20 milligrams or so in the deciliter, only in that case. But usually, if they have a little bit, at least in the 30s albumin, then 0.7, 0.6 should be given. But you shouldn't worry about protein energy wasting during that time because it is a short time frame. It is not enough time to have a long-lasting effect. That is why I really didn't even talk about acute kidney injury in my lecture. It's the chronic disease and the hemodialysis where it's long-term, where it starts having such a bad effect on the muscle mass and the protein energy wasting.
Because some nutritionists claim that AKI is a hypercatabolic state, and you can even give more protein, even up to 1.2 in AKI.
The guidelines say so. The guidelines say up to 1.2, but usually it is encouraged to stay up to 1.2 in very rare cases. And again, here comes the clinician's judgment on what is best, because the guidelines are always there and the clinician has to weigh the war and see what is best. If it is a 3 or 4 day event, it will not really harm the patient. And here comes what is the most needed strategy to save this person. And it might be that giving a 1.2 gram per kilo protein might be a little bit more harmful for those 5 days. But if we're talking about a longer phase, then that becomes more that you really have to do your best to give more protein. But within that small time frame, again, if the patient had a less than 20 albumin, then yes. But above 20 in their 30s, you can easily stay within the 0.7, 0.8, so forth.
One last question. Patients with proteinuria, whether it is as low as 2 grams proteinuria per day, up to 10 grams, how can you judge and advise for protein diet?
Okay. And before I continue to this, something that I used to do with acute kidney injury is I would give them keto analogs. I'm trying not to use brand names. There are these amino acids that are keto analogs. They are the branch chain amino acids. Leucine, isoleucine, and valine, and they are very often used for liver failure patients, but they can be easily used for kidney failure patients. Why? Because they're amino acids that are not used by the kidney. So in a case where I have an AKI patient where I'm really struggling to balance my judgment between should I give more protein or should I not overload the kidney, I would give a maximum of 1 gram per kilo, and the rest of that 0.2 give from branch chain amino acids. And that way I'm meeting the guideline, I'm giving, but I am not overloading the kidney. So just a judgment there. Sorry, for the proteinuria, I think the question was above 2. Can you repeat? I'm really sorry.
A patient with 5 gram proteinuria per 24 hours. What is his protein diet, and also if it reached up to 10 grams. So the question about proteinuria in general, how you will compensate him?
Am I assuming that maybe this is a nephrotic disease because such a high dose or a high level of, there
is many things to consider in the patient. Whether sometimes we have patient with proteinuria 1 gram and he's hypoalbuminemic, and the patient with 10 grams of proteinuria and he's not hypoalbuminemic. What is the level of creatinine also at the time of proteinuria? So all this has to be considered. If you may allow me to share you the answer.
Yes, of course. But in nephrotic disease, the maximum is 1.2 gram per kilo. That is the maximum. And surpassing that, it hasn't shown any safety.
Okay. So thanks for joining us this year. And I hope you join us next year, inshallah.
My pleasure and honor. Thank you for having me.
And we are sorry for being late for you and also
not
for
at all.
waking
Not
you
at
up
all.
early in the morning.
Not at all. Thank you so much. Have a good day. Bye-bye.
And now with Professor Mohammed Al-Hubain. Professor Al-Ghubain is a consultant pulmonary medicine in National Guard Hospital, and he is one of the committee in the pulmonologist doctor who's chairing the inputting the Saudi guidelines in pulmonology diseases. So we have the honor of having him today. And thanks, Dr. Ghubain, for joining us. And today we are talking about precision medicine for asthma for the first one. Thank you.
Okay, assalamu alaikum, good evening, and thank you for the attendance. For nice invitations. I know it's late, or already we are lagging behind the time, so I'm going to give two talks. I'm going to talk about initially about asthma, or particularly precision medicine for asthma. Means that individualized treatment for each particular patient with asthma. What's the best treatment for that particular patient? Because this is a trend. This is the way to manage asthma and many chronic medical disease currently by personalized medicine. So asthma definition based on the recent SGH guidelines, that asthma is usually is heterogeneous disease characterized by chronic airflow or airway inflammation, which means that asthma nowadays is not single entity or single disease. It's very complex heterogeneous disease. So each asthma patient is not mimicking the other asthma patient. And usually asthma characterized by the chronic airway inflammation. So asthma is a chronic inflammation, no longer is only considered as a bronchoconstriction as it used to be in the past, but now is a chronic airway inflammation with symptom of wheezing, shortness of breath, chest tightness, and cough, and usually variable over time and intensity. So the patient with asthma may have bad days and or good days in between. So it's not progressive, persistent shortness of breath like COPD. So it's variable over time and intensity, and usually is reversible expiratory airflow repetitions. So inflammations is the hallmark pictures or biomarkers for asthma. Unfortunately, based on these definitions, we cannot measure, or at most of the time in the routine practice, we don't measure inflammation in asthma, or we don't use inflammatory markers to diagnose asthma. It's difficult to treat asthma. If you see a patient who is very difficult to treat him, or if he has uncontrolled symptoms, continuous symptoms, despite being on maximum medical therapy, usually in step 4 and step 5 therapy with asthma. So those type of patients, basically, the first question you have to ask yourself why your patient has difficulty to control, difficulty with asthma. And the common things are common. The commonest one, and you go back to the basic approach to those patients, and the most common cause of the difficulty to treat asthma or uncontrolled asthma is basically poor compliance to inhaler, because this is a very common problem in asthma management, and there is at least sometimes more than 50% of asthma patients, they are not going a regular treatment for inhaled steroid. They stop their steroid and inhaled corticosteroid after they have recovered from their symptom of they have control. So number one reason for, and the most common reason for the difficult to treat asthma or control asthma is the poor compliance or poor adherence to the medical treatment, particularly in corticosteroid. And sometimes there is a problem with the type of inhaler or inhaler technique. So some patients with asthma not able to use the technique in the correct way. So because they have plenty of different inhalers, different devices, different technique. So there is some patient they have difficulty or understanding how to use the technique, the inhaler, the correct technique. So some patients they are using their inhaler, despite of that, still have uncontrolled asthma. And this is if you check their technique, you find that the wrong technique, and this is a very common problem in clinical practice. So adherence and technique is the most common cause of difficulty to treat or uncontrolled asthma. And others, like the patient continue to have exposure to the environment, patient has allergen exposure, continue to smoke. He has significant comorbidities or incorrect diagnosis. This is one of the causes of uncontrolled or difficulty with asthma. But please remember that the most important and the most thing you have to address in every time the patient comes to the clinic, to asthma clinic or patient or to your clinic, and he has uncontrolled asthma symptoms, please double check the adherence and the technique of his inhaler. Severe asthma, basically, if the patient has good adherence, technique, check the adherence is optimum, check the technique is great, patient no consistent conditions, and he's step 4 and 5. In spite of that, he still have uncontrolled symptoms. This is called severe asthma. So severe asthma definition different from difficult to treat asthma. So there are two different definitions. So severe asthma, basically the patient doesn't have any problem with adherence, doesn't have any problem with the technique, doesn't have any problem with a coexisting condition like chronic rhinosinusitis, reflux symptoms, sleep apnea. So all this addressed with the patient. In spite of that, patient on step 4 and step 5 therapy, in spite of that, we still have significant asthma symptom. And this is called severe asthma. So the definition of severe asthma. And severe asthma is usually uncommon because the bulk of asthma patients, 90% of asthma patients, basically they have controlled or mild to moderate asthma. Around 5 to 10% of those patients with asthma, they have severe asthma. So severe asthma patients represent around 5 to 10% of the whole asthma populations. What is personalized or precision medicine? So precision medicines or personalized medicine is individualized medicine. So you choose the correct treatment for correct patient, the right patient with the right drug at the right time. So what is the suitable or appropriate for this particular patient is not necessary to be appropriate for other patients. So every patient has his own unique profile, unique phenotyping, unique characteristics, unique endotyping, and so every patient you need to individualize his treatment approach depending on his phenotyping and type of asthma he has. So not every patient is anything other. So that is what's called personalized or precision medicine or individualized medicine. So the right patient with the right drug at the right time. If you look at the pathophysiology of asthma, so basically the most important cells in the pathophysiology of asthma is the T helper cells. So type 2 inflammation or helper or lymphocyte cells, these cells are the cornerstone in the pathophysiology of asthma. So the pathway or pathophysiology of asthma starts with type 2 lymphocyte cells. The type 2 lymphocyte cells reduce 3 important interleukins in the pathophysiology of asthma. Interleukin 5, interleukin 4, interleukin 13. Please remember these numbers because these are essential interleukin, which play a significant role in the pathophysiology of asthma and pathophysiology of inflammation in the airways. So interleukin 5, 4, and 13. And this is called type 2 inflammation. So if you heard about type 2 asthma or type 2 inflammation, this is what this means. This is what's asthma, which is triggering by the releasing of interleukin from the T helper or T lymphocyte or type 2 lymphocytes, producing interleukin 5, 4, and 13. So 4, basically, the job of the 4, interleukin 4, basically act through T cells, mast cell production of IgE. So interleukin 4 is basically precursor for production of the immunoglobulins E, while interleukin 13 basically work in the smooth muscles of the airways, so cause smooth muscles contractibility, so increase the thickness of the smooth muscles in the airway, in the wall of airways, and cause goblet cell hyperplasia and mucus production. So this is basically where IL-13 work. So IL-13 work through the basement membrane thickening, goblet cell hyperplasia, mucus productions, and smooth muscle contractibilities. Interleukin 4 is Ig mediated, while interleukin 5 is eosinophilic mediated. So interleukin 5 lead to productions of eosinophilia or eosinophils. So eosinophil mediated IL-5, Ig mediated IL-4, smooth muscle hyperactivity, contractibility, and mucus production is IL-13. Sometimes indirect way you can trigger interleukin or productions, which is 5, 4, 13 through the production or stimulations of the TSLB in the epithelial cells of the airways, and this is indirect production for production of the IL-5, 4, and 13, and eventually you're going to have high eosinophilia or high eosinophils, high IgE, and contractions of the smooth muscles of the airways. And this is also histopathologic cutting of the patient with asthma. Basically, you have a mucus plug, mucus secretions, smooth muscles hypertrophied, thickened basement membrane, thickened smooth muscles, airway smooth muscles, and also goblet cell metaplasia. So they have a phenotyping. Phenotyping means the clinical characteristic of disease. So the asthma phenotype, the terminology of phenotype means a clinical picture or characteristics or profile of the patient based on clinical features. While the endotype is biological markers for inflammation. So we have phenotyping, endotype. Phenotype, clinical characteristic of disease. Endotype is the biological marker of the inflammations. So you need to have inflammatory markers. What are the inflammatory markers? This is IL-5, IL-4, IL-13, eosinophils, IgE. So that's what. So examples of the phenotype or asthma phenotype, which is clinical characteristic of the disease. So asthma phenotype something in relation to the age and gender. So the female, they have different clinical phenotype compared to the male asthmatic patients. Children, young, elderly, they have different clinical phenotype, age of onset, comorbidities, obesity-related asthma, this different phenotype, comparing with asthma in non-obese patients. So this is different phenotype, different approaches, different treatments, and allergic features, smoking associated with asthma. This different type because this behaves like a chronic or irreversible airflow limitation, like a COPD-like pictures. So this is different phenotype. This is a clinical feature of the disease, clinical phenotyping of the disease. While the asthma phenotype, in this case, we got to divide them or classify them or categorize them in two different big classifications. We have type 2 inflammations. Type 2 inflammation, as I already explained to you, this is an T cell lymphocyte mediated through the different biomarkers, I5, 4, and 13. And this is represent around 70% of all asthma patients. And you have non-type 2, which is different pathophysiology. It is not related to the helper cell type 2 cells, not related to this interleukin. This is different things. So it's called non-type 2. So asthma is classified currently in two big categories: type 2 asthma, non-type 2 asthma. And non-type 2 asthma, three types: neutrophilic asthma, so the main cells of asthma is neutrophils, or pussy granulocytic asthma, or mixed, which is have high neutrophils, high eosinophils as well, or pussy granulocytic asthma. So the eosinophilic asthma, this is what is called type 2 asthma, which is main cells here in the biomarker for asthma is eosinophilia, and usually they have represent around 70% of the whole asthma populations. How to diagnose eosinophilic asthma? You need the criteria. To diagnose eosinophilic asthma, you need to have an pheno or a fraction of exhaled nitric oxide more than 20. So you have if you measure a pheno, should be more than 20 in children, more than 25 in adults. You have to have a serum eosinophilia. So you do CBC differential, check eosinophilia levels or counts in the serum. Eosinophil count should be more than 150. And if you check eosinophil in sputum, so you send sputum and check eosinophilia percentage, should be more than 2%. Okay, and this is, as you told me, this is mediated through interleukin 4, 5, and 13. And there are two types of eosinophilic asthma: early onset, childhood onset, and late onset adulthood. So it can be started at childhood, is usually triggered by allergen, or can be late onset in adulthood, mostly related to infections. So this is eosinophilic asthma. Criteria to diagnose eosinophilic asthma: high pheno more than 25, eosinophilia more than 150, sputum eosinophilia more than 2%, interleukins or biomarker 4, 5, and 13. The other non-type 2, the other classification of other class of asthma, which is non-type 2, which represent around 30% of asthma populations, they are different type. One is called neutrophilic asthma. Neutrophilic asthma, basically asthma patient who smoke and have high neutrophil in their sputum. So if you check their sputum is neutrophilic count, usually more than or equal 61% with induced sputums. And those patients, they do not necessarily to have high neutrophil in the serum. So serum neutrophil is not necessarily to be high. Okay, but they are smoker, they are usually obese, they have usually poor lung functions, very difficult controls, and usually they are very weak response to inhaled corticosteroid. Okay, so this is basically a profile of phenotyping of patients with neutrophilic asthma. So high neutrophil in the sputum, more than 61%, very low lung functions, or abnormal lung functions, poor asthma control, obese, and usually very poor response to inhaled corticosteroid. And those type of neutrophilic asthma or non-type 2 asthma, treatment for them is usually macrolide or LAMA, long-acting muscular receptor or anticholinergic receptor, not inhaled corticosteroid or LAMA. Pussy granulocytic phenotyping. So the other phenotype of asthma is called pussy granulocytic phenotyping. In this case, you have pussy, as its name indicates, to have low neutrophil, but low eosinophilia. So if you check the sputum eosinophilia, usually is that 2%. Check neutrophilic and this level in the eosinophilia is that 61%. So low neutrophil, low eosinophil in the sputum. Okay, and they usually have low pheno. Okay, and those patients are also difficult to treat. They usually, most of those patients, poorly controlled asthma. And they are not eosinophilic asthma, so they don't have too much eosinophilia. And usually those patients candidate for either bronchial thermoplasty or LAMA treatment, long-term anticholinergic treatments, because this is a nerve-related airway inflammations or inflammation-related nerve stimulation, not because of the eosinophilic inflammations. The other phenotype of asthma is basically related to drug-induced asthma, which is either induced by aspirin or non-steroidal anti-inflammatory medications like morphine and voltaren. So some patients using painkiller instead, and they get very bad asthma. So they get asthma exacerbations, nasal congestion, nasal polyposis, scarlet fever, or flushing of the upper part of the body and the head and neck. And this is represent around 15% of the severe asthma, and mainly in the male patients. And those patients usually young or middle age, and those patients who have nasal polyposis, chronic sinusitis, and treatment for those patients usually is avoidance and electrolyte modifier. You can give them montelukast. It's probably drug choice in those type of patients, and there's many clinical studies indicate that anti-IL-5 may work in this category of patients. Other phenotype, obese asthma. So asthma and obesity is different phenotype or different clinical pictures. Airway remodeling, chronic uncontrolled asthma for several decades, it become irreversible airway remodeling. Asthma in elderly, it can happen in elderly, even the age of 80 or 90 can be pure asthma. So asthma in elderly is different category of phenotype. Persistent airway obstruction, this is different phenotype. And other very important phenotype of asthma, clinical feature of asthma, or different entry of asthma is called exercise-induced bronchoconstrictions. Basically, pure bronchoconstriction happen after exercise, nothing else. So the patient doesn't have any atopy, no allergy, no night symptom, nothing. The moment he exercises, he gets bronchoconstriction. The moment he stops exercise, his symptom resolve, and this is called exercise-induced bronchoconstrictions. So based on the GINA guidelines, you have step 1, step 2, step 3, and step 4, and step 5 management of asthma, and each step has different recommendations, different treatment options. But commonly speaking, you have inhaled corticosteroid, you have LABA, you have combination ICS plus LABA, you have LAMA, long-acting anticholinergic, and you have leukotriene modifiers. And then if all this failed, you have to move to biological therapy or long-term oral corticosteroid. In step 1 and step 2, usually they are mild asthma, okay, or they are controlled asthma in between, have occasional symptoms. Those patients no longer giving short-acting beta agonists like phentoline alone to treat. Just give them BRM phentoline and leave them alone. This is not recommended and cannot be. Don't do it, please, like this. So don't treat asthma with phentoline alone. So no, is any type of asthma, whatever a patient has asthma, if it's mild symptoms, the patient should be inhaled corticosteroid for some time. So ICS, inhaled corticosteroid, is a cornerstone and essential treatment for patients with any stage of asthma, and even if mild triple symptom asthma, the patient should be inhaled corticosteroid. So in step 1 and step 2, you need to use low dose inhaled corticosteroid plus formoterol, for example. This is preferred, so you can use LABA plus ICS, formoterol plus ICS, PRN plus regular. So you have formoterol as fast acting, and plus you have maintenance treatment with ICS for a few weeks until they control their symptoms. But however, you can, the alternative for this, if you don't like to use formoterol and ICS in single device, still you have to give the patient ICS, so you can put the patient on ICS alone as a monotherapy in one device, plus you give him SABA, phentoline or salbutamol, short-acting beta agonist, and BRN basis, but with ICS. So all of the ICS, you can use ICS different device with SABA different device, or you can combine them in one device with formoterol or formoterol plus budesonide as single device. So please, any patient with asthma, whatever their symptoms, whatever their very minor, small symptoms, patient underestimate his symptoms. Maybe he doesn't come or doesn't think that he has mild symptoms. All those ICS is essential, starting step in management of patients with asthma. Biological treatment for asthma or precision treatment for asthma, they are basically target interleukin biomarker specific, treat that particular biomarker with that particular compound or biology or monoclonal antibodies. So these monoclonal antibodies treat that particular cytokines or interleukins. So what do we have in the market nowadays for biological treatment for asthma? We have 1, 2, 3, 4, 5 in the market. At least nowadays 4 already in the Saudi market available in most of the hospitals. We have anti-IgE monoclonal antibodies called omalizumab, the oldest one, and is there maybe more than 15 years in the market, since I think 2004 or 5. And the most widely used, it's called Xolair or omalizumab, is blocking anti-IgA. So remember, IgA come from interleukin 4. So interleukin 4 B cells, mast cells, IgA. So block IgA with monoclonal antibody omalizumab. This is one of the biological markers for a patient with asthma. If you choose the other biomarkers, the other monoclonal antibodies, which is block IL-5. IL-5, as you remember, in the pathophysiology of asthma and type 2 inflammation, is requirement for production of eosinophilia. So if you block IL-5, you block production of eosinophilia, so it stops inflammations or allergies. So anti-IL-5 monoclonal antibodies, usually you have 2 in the market. Mepolizumab, it's called Nucala or mepolizumab, which is already available in our market. And you have the other one, it's called Rizolumab, which is not available in Saudi Arabia, but available in other countries. But mepolizumab, Nucala is enough to if you would like to choose, or if you decide to choose anti-IL-5. The other is called anti-IL-5 receptor blocker. So you block the receptor of IL-5 with the drug called Finersa or benralizumab. And also, if you block anti-IL-13 and IL-4, so you have block 2 biomarker, 2 cytokines here, 13 and 4, with drugs called Dupixent or Dupilumab. So you have omalizumab, mepolizumab, benralizumab, Dupilumab. And if you look anti-TSLB, which is in higher level of the pathophysiology of asthma, tislelizumab is the drug of choice and currently market already approved by the American FDA and not yet available in Saudi market. But what you have in our market is 4 biological agents already approved by Saudi FDA for management of severe asthma. So if you see a patient with asthma, severe asthma, uncontrolled, in step 4 and step 5, and the first question you ask yourself before you jump to very expensive medications and very long-term commitment for biological therapy. Before that, go to basic. Ask yourself why. Why control? The common things are common. Problem with adherence with inhalers, problem with the technique, problem with comorbidities. Patient may have chronic rhinosinusitis, nasal polyposis treated. So this is called modifiable risk factors. Okay, so look for anxiety, depression, social difficulty, patient not happy, patient not satisfied with the medication. So all this you have to be addressed. Patient educations, very important. All this you have to address before you move to the next step in management of asthma, and you think this patient has severe asthma. So asthma educations, again, educations, very important. Treat comorbidities, consider non-biological treatment. Again, stepping up. In spite of this, in spite of all this, addressing all potential reversible modifiable risk factor, and in spite of that, patient still has severe asthma, uncontrolled asthma, significant symptom. By this time, you can label him as severe asthma. So by definition, this is severe asthma, and those type of patients, they are candidate or potential candidate for biological treatment. Before starting or to consider biological treatment, or you have to biological treatment for type 2 inflammation, type 2 asthma. So you check for blood eosinophilia, you check for FeNO, and check for also for lung function as well. And you do asthma control test, and from there you take it and you decide what is the best option of this biological treatment for the correct treatment. So if the patient has no eosinophilia less than 100, FeNO is low, high neutrophils, smoker, this is non-type 2, as I told you, asthma. Okay, this is non-type 2 inflammation. So those type of patients, they are not candidates for biological treatment. So those patients usually candidates for long-term oral corticosteroid or bronchial thermoplasty or long-term macrolide therapy or anticholinergic or what's called tiotropium or long-acting muscarinic receptor, usually tiotropium, Spiriva, and others. So those patients out of the biological treatment because they are non-type 2 inflammations. So biological treatment is only for type 2 inflammation. So then after that, you have to decide what's the best for your patient based on this FeNO levels, more than 25, eosinophilia more than 150, low lung functions, typical history of allergy and atopic asthma. So in this case, how to choose? Many factors. The most important thing is the patient preference, frequency, dose, cost, availabilities, all that's important because some of these biological treatments not always available in the same center. So some hospitals, they have it only in one or two of them. Some center hospital, they don't have it at all. So all these considerations, most of them sub-Q, but one of them can be given IV. Frequency, some of them given twice per month, every 2 weeks, some of them once per month, and some of them every 2 months. So all these considerations when you decide to treat your patient. But generally speaking, anti-IgE usually mostly for childhood asthma, severe allergic asthma, and usually with frequent exacerbations, high IgE. Anti-IL-5 and anti-IL-5 are usually for patient high eosinophilia, steroid-dependent asthma, frequent exacerbations, and the same apply for anti-IL-4, which is dupilumab, usually for high eosinophilia more than 300 or high FeNO more than 25 and steroid-dependent asthma. So the patient requiring frequent courses of oral glucosamine months. Then evaluate your patient after 6 months, see the patient responding. If responding to biological therapy, continue with these patients, responding based on the quality of life, asthma control test, and sometimes some physician repeat FeNO, but not necessarily based on clinical judgment. If the patient not responding to the particular biological treatment, you stop it, you switch it to other biological treatment. Review of the patient, stepping up and stepping down for every time your patient is responding to that particular biological therapy. The factor in biological therapy selection, there are many factors, but there are many factors to consider. Availability is very, very important. Patient phenotyping and phenotyping, type 2 inflammation, eosinophilic asthma. This is biological treatment for type 2 inflammation, not for non-type 2 inflammation. Okay. And patient characteristics, BMI and age, children, young, elderly. Route of administration, most of this medication is usually sub-Q. Frequency, like dupilumab, usually every 2 weeks. Xolair or anti-IgE usually depend on the IG level and the weight, so most of the time twice per month or monthly. Mepolizumab, single dose every month. Benolizumab usually given every 2 months, so different frequency of dose. Adherence, very, very important. Cost, and if the patient paying for it, or insurance approval and all these things. Safety, very important because, however, most of this biological therapy has been proven to be safe generally, and we don't have significant side effects. And the physician experience is very, very important. Finally, and it's probably the last slide, if you see a patient with asthma, first thing to see, to confirm diagnosis, and then address the patient asthma education, very important, address adherence, check the technique of inhalers, look for comorbidities, look for any environmental triggering factor, either indoor or outdoor, and then do the basic workup for the patient, check the eosinophilia, CBC differential eosinophilic count and serum, check IgE, send the sputum for eosinophilia count, check for aspergillus antibodies, look for ANCA because sometimes asthma this may exist, so you have to be sure that the patient doesn't have ANCA, do CT scan, do pulmonary function tests, and check for FeNO. And after that, if the patient has severe asthma, either identify your patient either type 2 inflammation, type 2 asthma, or non-type 2 asthma. If patient doesn't have severe asthma, mild asthma, then you go back to basics, step 1, step 2, step 3, and step 4, stepping up, stepping down approach therapy for patients with asthma. So asthma is very heterogeneous, very complex syndromes, different physiology, different typing, different phenotyping. So patients respond differently to different treatment. So this is called personalized approach or personalized treatment for asthma for different approach. So asthma is heterogeneous, complex syndromes. So you have to personalize treatment based on your patients. However, go back again before you jump for very expensive and costly medications and long-term commitment for patient asthma. Please go to the basic. Be sure that the patient has enough education about his disease. Be sure that the patient has enough adherence for his long-term inhaled cortisone inhaler. Be sure that the patient using inhaler technique is in the correct way. Please, ongoing exposure patients, sometimes patient exposure at home for pets, for animals, for cats, dogs at home, and this is the only reason why he's uncontrolled asthma. The moment you get rid of this triggering factor, the patient has asthma is controlled. Please look for comorbidities which make asthma uncontrolled. Then if you address all these things, and then think about biological therapy for patients with asthma. Thank you very much.
Thanks, Dr. Muhammad, for this nice presentation. We will meet you again, inshallah, after 60 minutes. No more questions from my attendants. I will
Assalamu alaikum. Thank you, Doctor. It's my pleasure to provide today, let's say, a brief about this topic, which is a trending topic that came in place to the healthcare institutions recently in the past 10-15 years. Again, I'm Fawaz Al-Kharabsha, the Group Experience Improvement Manager in Saudi German Health Group. I would like to start by seeing this let's say flower, which represents the experience, the overall experience, as soon as the guest, the patient, arrives to the healthcare institution. And depending on the touch points that happens in their journey and what kind of interactions that happens to them, it would either stay the same as what we can see it, or by either interaction, if it is not as per the expectations, it will start falling down until reaching a bad experience or remaining in the first one as a good one. So if we wanted to say what is the guest experience, what exactly we are talking about when we say the guest experience, or let's say the customer experience, Walt Disney have defined this as, I want to have a place that's as clean as anything could ever be, and all the people in it are first-class citizens and treated like guests. So another eminent person in Disney called Van France said that I believe that everybody that works needs some intangible goal, that we all want something that's bigger than what we are doing. So to have a common purpose, the common purpose by creating empathy, by providing extraordinary care for people from all ages and everywhere. So when we say specifically now, what is the patient experience? The patient experience are being defined as the sum of all interactions shaped by an organization's culture that influence patient perceptions across the continuum of care. And of course, it is integrated from the workforce experience through the community experience and finally by the human experience. Now, what matters a lot to the patients, to the guests, and so on, let's say, going through here, we came to this kind of highlighting what matters the most: to deliver, to build, to act, and to be an outstanding experience by providing compassion through empathy and caring culture. Now, when we see an organization similar to Walt Disney and another organization such as Saudi German Health Group, we are in the same sector as Disney, offering a different experience. This is from one point of view. But the main difference here that in Disney, for example, they do the experience by meeting the emotional needs of a family to have fun together. But in a healthcare institution, meeting the emotional needs of a family going through fear, pain, and even tragedy together. So that's what makes the compassion is one of the main differentiators in the experiences here. Gestology is being defined as the art and science of knowing and understanding your guests. So preconceived notions and wants, the needs and feelings drives a person for their expectations. So once we meet these expectations, we can say that we have implemented this Gestology in the best way possible. One of the initiatives that was adopted by the Saudi German Health Group regarding improving the satisfaction of the patients and their beloved ones was a program called CARE. CARE is not only about the caring, but also it's an abbreviation that stands for Connect, Assist, Respect, and Explain, which was some standards, some way of communication that was established to show empathy, which resolves in the eye contact, the facial expressions, the posture, how we affect the people, the tone of voice, hearing the whole patient, and how we respond to them, which will eventually lead to better communication. One of the person-centered care tips that we have, let's say, established or adopted, which is now, let's say, a global or an international guidelines that is existing in the international accreditation bodies and national as well, which is the person-centered care, the patient-centered care principles by several organizations such as Planetary International, such as the Joint Commission International, and even the Saudi Central Board for Accreditation of Healthcare Institutions, as a main integral part of providing the patients and their families with their rights and responsibilities in the best way. So one of the main thing is by engaging the patients in the decision making. And here in our group, we have established some initiatives, such as a program called the Care Partner, where one of the beloved ones of the patients, based on the selection of the patient, either a friend, a family member, and so on, is going to be selected to be a care partner to the patient, where they will assist the healthcare providers in the hospital during their stay, and even post to their stay in the hospital, in providing the care as much as they can do it. The shared medical records, the bedside shift handover, the shared decision-making, of course, providing the patients upon admission with something called the patient or the guest preference passport, where the patient will start selecting their preferences regarding their stay in the hospital. So I will summarize everything with these three sentences, that it is a great power for the voice of the guests. Every feedback is a gift for us to improve, learning, engaging everyone in the solution, and then make the change. Thank you very much.
Now we'll come back again for Dr. Mohammed Rubain, our professor and pulmonology consultant, for another fruitful lecture about COPD and its recent updates. Welcome again, Dr. Mohammed.
طيب, Assalamu alaikum, good evening, and my pleasure to be again talking about rather of asthma. So I talk asthma, now we talk about COPD, but asthma and COPD both are airway diseases, And but the only probably difference between them is the COPD disease for elderly patients, while asthma in young patients. And there's many guidelines internationally and even locally about management of COPD. But I'm going to review what we call GOLD or Global Obstructive Lung Disease Initiative or guidelines, which is basically guidelines produced from WHO. And there is many international members of this guideline have researched and published. This guidelines is basically started in 2000, started I think 2004 or 2005, and then every year they are updated. But there is a significant changes in the new guidelines, which is it's called GOLD 2023. So this is the next year, or basically just released last month, and for the new guidelines. Why I'm insisting about give you update what is new with this guideline, because there's a lot of changes, and there's a lot of recommendations which is completely different from what is the old guidelines. So I'm not gonna review the disease itself in details. So we assume that you have a background, a basic background about COPD, diagnosis, management, treatment options, classifications, and then based on this, what is new in the recent guidelines. Okay, so one of the most important changes in the new guidelines or update the guidelines, they changed the definition of COPD. So the old definition of COPD no longer existing. So they're just modifying or changing of the definition of the COPD. So COPD is a chronic obstructive pulmonary disease, is heterogeneous. So they add the word heterogeneous. So in the past, in the previous definition of COPD, the word heterogeneous was not existing. And now they add heterogeneous because COPD is not a single disease. It's a very complex disease. It's bronchitis, emphysema, mild, moderate, severe. So it's very complex disease. So every patient with COPD behaves differently from other patients with COPD. So that's what's called heterogeneous lung condition. So they add the word heterogeneous lung condition characterized by the chronic respiratory symptoms. So symptoms of COPD usually chronic, dyspnea, cough, sputum production, and frequent exacerbation. So exacerbation is very, very important presentation of patient with COPD. And usually due to abnormalities of the airways, either the patient has a chronic bronchitis or bronchiolitis, or abnormalities in alveoli and emphysema. And most of the time, the patient has a combination of both chronic bronchitis and emphysema together that cause persistent and often progressive airflow obstructions. So very important in this definition of the symptoms, usually persistent usually and progressive, means the symptom of COPD, if it's happened, it's usually persistent and continuous, is not reversible, doesn't go back normal. So it's completely different from asthma, for example. Asthma, in the previous lectures, that asthma usually is reversible and vary over time and intensity. Now, while in COPD, usually the patient has daily, persistent, progressive, continuous, worsening respiratory symptoms and airflow obstruction over years and years, and usually over decades. So this is a new definition of COPD. If you look at this new definition, it's more precise and more reflect the clinical phenotyping or pictures of the disease, and tell you about the nature of the disease and outcome and prognosis as well in the patient of COPD. So lung function, generally speaking, what happens for lung functions over years? At the age of 20, somebody who is healthy, his lung function or his FEV1, forced expiratory volume per second, usually around 95% of the predicted. So you completely have normal FEV1. If you never smoke and become healthy the rest of your life, by the age of 60, 70, your FEV1 dropped to 71 or 75 or probably 80%. So this is dropping around 20% over 5 decades. This is called physiological decline on lung function in healthy persons or individuals. This is normal physiology. Okay. So this is age related. So with age related, it's expected that drop around 10 ml per year, something like that, or 10 to 15 ml per year. So by the age of 60, your FEV1 is going to be 71%. However, if you start to smoke, by the age of 20, okay, by the age of 60, your lung, your FEV1 is going to be probably 50%, and you are going to have COPD. Okay, so over decades, if you read red color here, this is dropping in FEV1 over decades in smoker, and they have COPD. If you smoke, your lung dropping so quickly, faster than healthy age-related dropping in your lung function, FEV1. If you born with a small lung, your lung function at the age of 20 is not same like healthy, it's going to be low. So FEV1 is something like around 70%. So the age by the age of 20 years, your FEV1 is around 70% predicted if you're born with a small lung. Okay, and then with aging, by the age of 70, your lung is going to drop by around 16%, but not COPD. But if you have COPD, you'll drop further. So the risk factor here, looking for this one, risk factor for COPD or dropping or worsening lung function over decades and decades is basically smoking, number one, and this is well known and known for decades. Okay, another one is if you're born with small lung volumes, or premature born, okay, and your lung small, this is per se is risk factor to having COPD in elderly in your age and when you get older, even if you are not a smoker. So now the E2 types for COPD or terminology or taxonomy or proposed taxonomy or E2 typing for COPD is different from what used to be in the previous guidelines. So if it's gene related, it's called COPD-G. So this is called genetically determined COPD. It's nothing to do with smoking. So this is a typical example. It's alpha-1 antitrypsin deficiency in young emphysema, young alpha-1 antitrypsin deficiency. Patient never smoke, and this is COPD. But this is COPD-G, genetically determined. If you have an abnormal lung development, a small lung, it's called D, or abnormal development, so COPD. So if you have small lung, born with small lung, this is a risk factor for COPD, even if you've never been a smoker. Another, classical risk factor for COPD, as we know, tobacco, and this is called COPD, smoking-related COPD, COPD-C, and this is all type of tobacco: cigarette, active, passive, vaping, e-cigarette, cannabis, drug abuse, and all these things is a risk factor for COPD. This is smoking-related or tobacco-related COPD. Other type of COPD is basically air pollution related. So if you are living in very polluted city or industrial city for several decades for your life, after 20 years exposures, you are going to have COPD. So it's called COPD-P, or pollutions, or polluted, the exposure to pollutions, air pollutions, wildlife smoke, occupational hazard, and all these things. So factories, polluted area, living in very industrialized cities make a risk factor of COPD. This is called COPD-B, even if you don't smoke cigarettes. And the other one is a chronic infection, like TB infection during adult childhood or even young age. HIV infections make you a risk factor of COPD in the future. So this is an infection related to COPD, and asthma related to COPD, COPD, when they have uncontrolled persistent asthma for several decades, become irreversible and become fixed airway obstruction and mimic COPD. So COPD per se is not only because of tobacco or smoking, as it used to be, could be genetically determined, could be small lung volume, born with small lung volume, could be related to the air pollutions, industrialized cities or polluted cities, chronic infections, and asthma. So you have to have risk factors. You have environmental interaction between the gene, environment, and time frame. And it's called G2 mix, gene, environment, time. So you need that, you have to be susceptible, genetically susceptible to COPD. You have to have environmental factor, air pollution, smoking, whatever. And this is happening over time. It doesn't happen with 1 year, 2 years, 5 years. You need decades, at least 15 years of exposures to 1 decade, 2 decades, 3 decades. So this time factor, gene, environment, time factor, interactions, eventually you're going to have COPD. So based on this, COPD disease of elderly is not disease of young patient, except for alpha-1 antitrypsin deficiency. So most of COPD, when they present to the hospital, so they start to have symptoms of COPD, they present after the age of 50 years old. It's not something younger than this age. So the symptom of COPD, usually dyspnea, as I told you, usually dyspnea is different from asthma. Usually dyspnea is irreversible, progressive, persistent, worsening with times. So the moment the patient has dyspnea now, it's unlikely that he's going to go back to his normal. He's going to worsen progression. I have to stop progression. So treatment for COPD is stop the progression of the disease at that particular stage. You don't want the patient to go to the further worsening or the next stage. So dyspnea is really very bad in patients with COPD, progressive or persistent. Recurrent wheezing and cough and chronic cough is part of the disease. Recurrent lower respiratory infections, and usually they should have a risk factor of COPD, as I already told you about risk factor. Common classical tobacco, but there's many other risk factors which already mentioned. Spirometry is a must. To diagnose COPD, you have to do spirometry. There is no doubt. Okay. And the criteria to diagnose spirometry, the FEV1 over FVC should be less than 70%. If this ratio is not less than 70%, this is not COPD. Okay. So everybody agree that you need to do spirometry. Post-bronchodilator response, FEV1 or FVC should be less than 70%. So this is a normal spirometry. This is time, this volume, this is FVC, FEV1, FVC over FVC ratio here is 80% normal. In the patient with COPD, it looks like this. So reduce FEV1, mildly reduce FVC. So the ratio here, FEV1 over FVC is less than 70%. This example is 0.56. So this is typical obstructive pattern, so obstructive spirometry. So spirometry is essential, needed, required for diagnosis COPD, assess severity of COPD, follow up pre-operative response treatment, and many other indications of COPD, but they are essential to diagnose and assess the severity and follow-up assessment in patients with COPD. So COPD again, patient who has FEV1 over FVC ratio post-bronchodilator should be than 70%. Then you classify the degree of obstructions or lung function based on FEV1. So if the patient has FEV1 is more than 80%, this is called mild or gold 1, or mild COPD. Moderate COPD, the FEV1 ratio usually from 50 to 80%. Severe COPD from 30 to 50% is usually this is 50%, and very severe or gold 4 usually FEV1 is 30%. So you have this based on FEV1 alone. So you have a mild, moderate, severe, and very severe, or gold 1, gold 2, and gold 3, and gold 4 COPD. The pre-COPD, okay, this is different entity. So sometimes you find the patient who has an FEV1 over FVC ratio more than 70%, and this per se excludes COPD, because this is not fit the criteria to diagnose COPD. However, if you do CT scan for those patients, you find emphysema. So sometimes you find emphysema, air throbbing, but the ratio is less than 70%, more than 70%. This is called the pre-COPD or preserved ratio with impaired preserved ratio with impaired symptomatic emphysema and hyperinflations. And this is and risk factor for those patients. Usually they are going to lose COPD within 5 years usually. Okay, and those patients, be sure before you label them as a pre-COPD, be sure they don't have a mixed obstructive and restrictive lung disease. So we call this a mixed picture. So if they don't have interstitial lung disease or restrictive lung disease and pure emphysema, it's called the pre-COPD. And this new terminology is used on this new guidelines. So the dyspnea scale in patient with COPD, you have to measure the quality of life patient with COPD. You have to use scaling. One is called modified MRC dyspnea scale, scaling from grade from 0 to 4. 0 almost negligible or minor symptoms. Okay, I only get breathlessness with strenuous exercise, so it's very minor triple symptoms, almost asymptomatic. While grade 4 is the most severe form of the symptom-related quality of life. So the patient not able to leave his home, not able to wash his face, not able to change his dress, is bedbound, almost bedridden, disabled because of significant dyspnea. And anything between them, grade 1, grade 2, and grade 3. So use it in the clinic, grade your patient, and ask your patient which grade the patient classified. The other tool is called CAT assessment tool, and CAT assessment is called about symptoms of cough, phlegm, chest tight, my chest does not feel tight at all, chest tightness, walk in hill or one flight, limited activities, leaving my home, sleeping quality, and feeling a lot of energy, of fatigue. So the patient is scoring and asking these questions, and he's scoring from 0 to 5. If it's 0 is almost nothing, no symptom at all, or poor, a good quality of life, is almost negative. If he's scoring 5, he's too much symptoms. So that's significant symptoms, and the patient scoring in between them. So if you look at this one, it's like maximum scoring 5 is 40, minimum is probably 0, which is most of the patients have it. So if CAT score, if it's above 10, based on the score, patient has a poor quality of life. Patient symptomatic COPD. If the CAT score below 10, patient has a good quality of life, almost asymptomatic, and he still has a good functioning in his life and his job and his socializing and all, and sleeping and all, doesn't have fatigue. Okay, so scoring this patient, put your patient in which category, scoring above 10 and below 10. Now, global or gold ABE assessment tool. Patient has symptoms, do spirometry, confirm diagnosis. If he found offers FEC less than 70% post-bronchodilators, look for FEV1, decide your patient, he's in a mild, moderate, severe, severe, or gold 1, gold 2, gold 3 grading based on FEV1. And then what you will do, use either MRC or CAT. If you use CAT, categorize your patient less than 10 or more than 10, or MRC 0, 1 or more than or equal to. So this is category is minimal symptoms, good quality of life. Patients have normal when socializing and functioning and everything he's socializing everywhere, and he doesn't have significant symptoms. And those patients usually categorize them in category is A. It's called A. So it's called COPD A or category A. Patient has significant symptoms, CAT score more than 10, or MMRC less than or equal to, categorize B. So why you are using CAT scoring quality of life? Because you want to categorize your patient either A or B. And then a third tool to assess COPD, history of exacerbations in the previous 12 months. If the patient has 2 or more exacerbations or 1 admission to the hospital in preceding 12 months, this is E. If patient has no exacerbations or minor or mild exacerbation, but he doesn't require admission to the hospital, maybe in the clinic, give him oral antibiotic or oral steroid for 3 days, this is category A or B. So if you're looking for E, which is in the previous guidelines, if you remember, it was A, B, C, D. Now they take C out, D out, merge them together as E. E stands for exacerbations. So that's why emphasizing here in new guidelines or new updated guidelines that exacerbation history is a very significant finding in the patient with COPD, that exacerbation per se reflect the prognosis and mortality and outcome, even if the patient has no symptoms of very good quality of life between them. So exacerbation probably the most important prognostic factor in mortality in patient with COPD, history of exacerbation. So the patient had exacerbations in the preceding 12 months, more than 2 or 1 admission in the last 12 months, this is a very poor prognosis, and usually mortality rate is up to 50% in the next 2 years. So what are medication for COPD? Availables. We have short-acting beta agonists, salbutamol and phentermine or terbutaline, bricanine. You have long-acting beta agonists, usually formoterol, indexerol, salmeterol, phenytosterol, many. Okay, and you have short-acting anticholinergic, ibuprofen, bromide, atropine, and you have long-acting anticholinergic, LAMA, and commonly used in the practice tiotropium, Spirica, but there's many others. Long-acting beta agonists like aclidinium, glycopyrronium, tiotropium, imiclidinium, glycopyrrolate. Okay, but what is used here is tiotropium, most commonly used, available everywhere. Okay, and then you have combined LABA and LAMA. If you combine LABA and LAMA together, if you combine formoterol and aclidinium, Duaclair is that this is a generic name. But what is available, or most of the time, if you combine indextrol and glycopyrronium, Altebro, maybe some you already use it or heard about it. Phenytosterol and imiclidinium is called Anora, and this is Ellipta. And oldaterol and tiotropium is Stirlito. Okay, this combined LABA and LAMA. If you combine LABA and ICS, if you combine LABA, long-acting beta agonist plus inhaled corticosteroid in one single device, combine formoterol, beclomethasone, poster, combine formoterol, budesonide, Symbicort, and there's around 6 or 7 already in the market, but the wide use is either phenytoron, fluticasone, Relfar, or formoterol, budesonide, Symbicort, or delmiterol, fluticasone, which is serotype. And now we have triple combination therapy, ICS, LABA, and LAMA in single device. And the wide use is phenytoron as LABA, fluticasone as ICS, imicridinium as LAMA, and it's called Trilogy, and it's used for patients with severe COPD. We have maybe other 2 or 3 combination therapy, triple therapy for asthma, for COPD, but probably most of them is not yet available in the market. Patient with COPD, as you remember in asthma, the cornerstone treatment for asthma is inhaled corticosteroid. First line treatment for asthma, even for mild asthma, inhaled corticosteroid. In COPD is opposite. Inhaled corticosteroid is not first and not second line treatment for COPD. So don't throw ICS for COPD, even if it's mild or moderate COPD. It's only indicated if the patient has severe COPD, significant symptoms, frequent exacerbations, multiple admissions to hospitals, more than 2, if he has blood eosinophilia more than 300, and if he has asthma with COPD together. In this case, you add ICS. If it's not the case, just COPD, even category A or B, usually not ICS. Usually treatment with LABA and LAMA alone is enough. If the patient has frequent exacerbation, but frequent different several pneumonia, don't use ICS because ICS per se increases risk of pneumonia in patients with COPD. If the patient has blood eosinophilia or serum eosinophilia less than 100, it's against use of ICS. So ICS only used in patients with severe exacerbations or eosinophilia more than 300 in patients with COPD or they have asthma at the same time. Oxygen therapy is essential. Evidence A is decreased mortality in patients with COPD. There's no doubt about this. There's indication for oxygen therapy. Please put the patient in oxygen therapy. However, if the patient at risk, oxygen saturation is normal, but with 6-minute walk test or with exertions, he's desatting, this is not indication for oxygen therapy. It doesn't change the mortality, it doesn't prevent exacerbations. So don't put patient on long-term oxygen therapy if he desatting with exertion only, but at risk he's maintaining oxygen saturation. And this clearly with many clinical trials proven, which came the same conclusion with evidence A studies. It's a meta-analysis or strong randomized clinical trial. And then phase home BiPAP used in patients with COPD. They have severe, frequent exacerbators, and they have type 2 respiratory failure, hypercapnia, if the PaCO2 more than 53. So if the patient has a PaCO2, carbon dioxide, more than 53 millimeter mercury, in stable conditions, and has persistent hypercapnia, frequent exacerbation, severe COPD, home BiPAP. One application, home BiPAP, is one part of the routine, or at least becomes standard care of those patients with COPD. What bronchodilators, again, LABA, LAMA, not ICS. ICS not as a monotherapy. If you add ICS used with LABA or LAMA, triple therapy in severe cases. But most of patients with COPD, LABA alone, LAMA alone, or combination of therapy of patients with COPD is a standard or the first line treatment for COPD. Again, same things. LAMA alone, superior to the SABA alone, but LAMA is superior to LABA alone. LAMA ICS is only used as triple therapy in patients with multiple admission, multiple exacerbation, or high eosinophilic count, or they have if they have evidence of asthma. So this is again categorize your patient. You categorize the patient either A, B, or E. If it's A, treatment choice, A means minimal symptoms. Almost patients has almost no symptoms, very minor symptoms, no exacerbations, stable, doing well at home. Those patients probably bronchodilator is the first line treatment is more than enough. So you just give him SABA, short-acting beta agonist, salbutamol, alone as a PRN, and they are fine, following them later on, repeat lung function later on. If they have significant symptoms, poor quality of life, limitation of activities, fatigue, chronic cough, sleep symptoms or night symptoms, and they are group B, but they don't have frequent exacerbators. So this is called dyspnea, dyspnea phenotype or trait. Dyspnea trait. Drug of choice or inhaler of choice in those patients, combination of LABA and LAMA. Long-acting beta agonist, LAMA. No ICS, no head corticosteroid in these patients. Group E, frequent exacerbators, 2 or more exacerbators, or at least one admission in the preceding or previous 12 months. Again, LABA and LAMA is a first-line treatment, but you may add ICS, so you give triple therapy if they have evidence of severe exacerbators, frequent exacerbators, if they have eosinophilia more than 300. Otherwise, don't give ICS in those categories. So if you look at this guidelines or recommendation, ICS in health corticosteroid has very limited role in patients with COPD, even severe one. Okay, and unless they have asthma or high eosinophilia or frequent exacerbators and very palliative, very terminal case of COPD. And however, you have to remember this frequent exacerbation is due to pneumonia. Every time the patient comes with pneumonia admission with COPD, ICS is out. Please don't add them ICS. Just keep them in LAMA. If it doesn't work, put them in home buyback and home oxygen, and they should be okay. Review the patient every time management cycle. Review, assist, adjust to your patient, assist him, assist on the technique educations. And remember, non-pharmacological treatments is escalated, switch and here depend on patient response and patient quality of life and patient satisfaction and preference as well. And patients, dyspnea, LABA or LAMA, if it's patient in LABA or LAMA alone, combine them together. If patient frequent exacerbators, LABA, LAMA alone, combine them LABA and LAMA. If patients still have frequent exacerbators, high eosinophilia, in this case, you add LAMA, and ICS, triple therapy in one single devices. Or if it's single device not available, you can put in different devices. You can use LABA, LAMA in one device and LAMA in different devices. If patients still have significant exacerbator, then in this time you may add macrolide long-term 3 times per week. Azithromycin is probably as a long-term anti-inflammatory, probably is option in those patients. Please remember, COPD management is not only inhalers. Yes, pharmacology is important, but this is only part of the management. Management of COPD is including also non-pharmacological management of COPD. Smoking cessation, essential as a must. It's not optional for the patient. Every patient with COPD, if he's continuing smoking, should stop smoking. By counseling, by sending him to a smoking cessation clinic, by re-counseling, by giving nicotine, different modality of nicotine, Champix, whatever, but it's essential. Smoking cessation is very, very essential for patients with COPD A or B or E. Rehabilitation activities, exercising, fitness, walking, exercising is very important. Stable patients with COPD. If they're stable, they should exercise. They should have and go in pulmonary rehabilitation program is essential. Vaccinations, flu vaccine, COVID vaccine, pneumococcal vaccine, bird vaccine, and nowadays shingle vaccine is also very essential for patients with COPD in all types, A, B, or A. Vaccination is essential, especially flu and pneumococcal vaccine is a must for every patient with COPD. This is the last slide. So what's the new one? This guideline. The new is that, as I already showed you on the first slide, new definition of COPD. It's basically the definition based on, the emphasis about heterogeneous, complex syndromes, chronic bronchitis, emphysema, chronic, progressive, persistent airflow obstructions, usually irreversible or partially reversible. So this is a very important part of the definitions. The other important in this new guideline, they're talking about non-tobacco risk factor, which already I told you about it. So not the classical risk factor, tobacco products, cigarette and all that type of tobacco products, but now talk about air pollutions, biomass, small lung, birth with small, born with a small lung, okay, history of asthma, chronic infection like TB and HIV is a risk factor of TB. So there's many other genetically susceptible, like alpha-1 antitrypsin. So sometimes unknown or diabetic, unknown risk factor, no obvious for physician risk factor of patient COPD. So none other risk factor, please keep in mind. If you see a patient with COPD and he never smoked, please think this is not always related to smoking, maybe due to other causes like pollutions, air pollution, industrial cities, and living in very crowded cities. Early recognition very important for COPD, because earlier they recognize the patient, the better outcome, the better prognosis. The earlier interventions, you're going to avoid a lot of complications, long-term complications. Early COPD and also the pre-COPD PR ISME, as also I told you about it, which is the FEV1 ratio is more than 70%. But if you do see scanning for emphysema and hyperinflations, and this is basically is not COPD, it's called early COPD or pre-COPD, and it's in the future patients are going to having a risk of different COPD in 5 years. Again, group A, B, and most of group E, please, first line treatment for COPD, not inhaled corticosteroid. First line treatment for COPD is combination of LABA and LAMA. And single device, nowadays in single device, I'll show you. So LABA, LAMA is first line treatment for patient COPD in group B. And in group E, again, LABA, LAMA. Okay, you may add in severe COPD, you may add ICS in the case already I mentioned about it, which is basically eosinophil count more than 300, history of asthma, and also if the patient has frequent exacerbations, frequent admission to hospitals, and very terminal cases of you may add ICS. But still, LABA, LAMA is the cornerstone first line treatment for patient with COPD. Very, very important. COPD management is not only inhalers, not only medications. Please remember, non-pharmacology, vaccination, smoking cessation, pulmonary rehabilitation, rehab, exercise, diet, smoking cessation, vaccination, they are essential and they must. Okay, you cannot manage patients with COPD without offering this approach or this intervention for your patients. And again, if patient need ICS, the best option, single device, your LABA, LAMA, ICS. We've already showed there's 4 different modalities nowadays, different devices, different combination is preferred because this single device and more convenience for the patient to these, and this is only for group E patients. I'm done. Thank you very much. Thank you for listening, and I hope it was very useful. And if you have any questions, I'm ready to answer questions.
Assalamu alaikum. Assalamu alaikum. Thanks, Dr. Muhammad, for this nice presentation. Currently, we don't have any question. It seems that everything was quite clear. Thanks for giving us some of your time. And now we will move to the next presentation with Dr. Rasha Hindi. Dr. Rasha is consultant pulmonologist, SGH Riyadh, and she has a doctorate degree from Egypt. Dr. Rasha will talk today about IPF or interstitial pulmonary fibrosis. Kindly share your screen, please. Dr. Rasha,
are you hearing me? Dr. Ahmed, are you hearing me? Dr. Ahmed? دكتور أحمد.
أيوة مع حضرتك اتفضل.
تمام. Good night. I'm happy to talk with you about my lecture, IPF or idiopathic pulmonary fibrosis. I'm Dr. Rasha, pulmonology consultant at the German hospital. First, we have to know that IPF is the most common of the spontaneously occurring diffuse parenchymatous lung diseases, which is known as idiopathic interstitial pneumonias, which include a variety of idiopathic interstitial pneumonias like non-specific interstitial pneumonia, desquamative interstitial pneumonia, respiratory bronchiolitis associated interstitial lung disease, acute interstitial pneumonia, lymphocytic interstitial pneumonia, and cryptogenic organizing pneumonia. IPF is a spontaneously occurring or idiopathic specific form of chronic fibrosing interstitial pneumonia limited to the lung and associated with characteristic usual interstitial pneumonia pattern on high resolution CT and lung histology. A radiographic or histologic finding of usual interstitial pneumonia may be found in non-idiopathic interstitial lung disease, and so it is not synonymous with the clinical diagnosis of IPF. Pathogenesis of IPF is complex and likely involves cycles of epithelial cell injury and associated repair. Both cases of idiopathic pulmonary fibrosis are sporadic. Familial cases have been described. Familial pulmonary fibrosis account for less than 5% of patients with IPF, and the inheritance occur through autosomal dominant pattern with variable penetration. Within a family, affected patients may have different interstitial lung diseases. The familial pulmonary fibrosis has no distinguishing features and require thorough family history. A number of genetic variants have been associated with this type. For example, gene for surfactant associated protein A and surfactant protein C, mucin 5B familial pulmonary fibrosis appear to be associated with increased incidence of bronchogenic carcinoma. In patients with familial pulmonary fibrosis, smoking contributes to shortened transplant-free survival and development of more advanced radiologic disease. Clinical features which are suggestive clinical manifestations of IPF. The patients with IPF typically present at the age of 60 years or older. The majority have history of cigarette smoking. They mostly report the gradual onset of dyspnea on exertion and unproductive cough over several months. Fatigue, fever, myalgia, arthralgia are rarely reported. As with all patients who present with interstitial lung disease, the history should include questions about family history of lung diseases, symptoms suggestive of rheumatic disease like arthralgia or dry mouth, current and recent medications, exposure to fumes, dust, or therapeutic irradiation. On physical examination, we can find basilar crackles, but rarely may be absent or only heard unilaterally in early disease. Patients with more advanced disease may have an inspiratory squeaks due to traction bronchiectasis. In early reports, finger clubbing was reported in 45 to 75%, but now they showed that the clubbing is a manifestation of advanced IPF. Evaluation of a patient with suspected IPF require a combination of steps and include the following: exclusion of identifiable causes of interstitial lung disease based on history, physical examination, and laboratory testing, assessment of the pattern and severity of the respiratory impairment on pulmonary function test, high resolution CT of the chest to confirm presence of interstitial lung disease and characterize the distribution and the pattern of obesities. Multidisciplinary clinical, radiologic, and pathologic discussion to maximize the accuracy of final diagnosis. Patients with newly diagnosed interstitial lung disease should have detailed assessment for the potential causes of interstitial lung diseases like medications, amiodarone, bleomycin, nitrofurantoin, exposure at home or at work to agents that cause hypersensitivity pneumonitis, work exposure to asbestos, silica, other fumes, vapors, dust, signs or symptoms of rheumatic disease, and family history. No laboratory tests are specific for the diagnosis of IPF. So the rule of laboratory testing in patients with newly diagnosed interstitial lung disease is only to exclude, to identify or exclude processes in the differential diagnosis. For patients undergoing initial evaluation for possible IPF, serological studies may be of benefit in identifying subclinical rheumatologic disease. We typically obtain tests for anti-CCB, anti-nuclear antibodies, and rheumatoid factors. C-reactive protein and ASR are non-specific measures of inflammation and are obtained by some experts. Other tests like antisynthetase and other myositis panel antibodies, creatinine kinase, aldolase, Sjogren, and scleroderma antibodies may be helpful in selected cases with suggestive symptoms or signs. Complete pulmonary function should be done to patients with suspected interstitial lung disease, including spirometry, lung volumes, and the LCO. In patients with the IPF, the pulmonary function typically demonstrate restrictive pattern with reduced forced vital capacity, but normal ratio of forced expiratory volume in 1 second, and reduce the LCO. And as the disease progresses, there is decrease in the 6-minute walk distance. This radiograph is typically obtained in adults with cough and or progressive shortness of breath. The most common finding in IPF is increase in reticular marking, although this is not a specific finding and may be associated with other interstitial lung disease or heart failure. High-resolution CT tests should be obtained in all patients with suspected IPF. The technical requirements for high-resolution CT scanning patients with ARDS according to the guidelines should include submillimetric collimation, reconstruction of thin section equal or less than 1 millimeter images, and supine inspiratory, full inspiratory film, and expiratory images. The characteristic features of IPF on high-resolution CT: peripheral basilar predominant obesities associated with honeycombing, traction bronchiectasis, or bronchioloctasis. Honeycombing refer to clusters of cystic air spaces from 3 to 10 millimeter in diameter and subpleural location in the usual manner. The histopathology of radiological changes in IPF demonstrate progressive bronchiole remodeling as a continuum that includes both honeycombing and traction bronchiectasis. ده شكل idiopathic shape of idiopathic pulmonary fibrosis on high resolution CT chest, and this the subpleural honeycombing inside the yellow circle. While honeycombing is essential to make definite a high-resolution CT at the diagnosis of usual interstitial pneumonia, traction bronchiectasis also indicate probable usual interstitial pneumonia. Both definite usual interstitial pneumonia and probable patterns on high-resolution CT show histological confirmation of usual interstitial pneumonia in greater than 8% of the time. Following multidisciplinary discussion and in appropriate clinical setting, the guidelines endorse avoidance of additional histologic confirmations in patients with this radiographic pattern unless there is additional clinical concern or an alternative diagnosis. Ground glass obesities that are superimposed on a fine reticular pattern can be present in usual interstitial pneumonia, but ground glass obesities without associated reticular pattern or extensive ground glass obesities that are more prominent than reticular changes are inconsistent with usual interstitial pneumonia. However, in the setting of acute exacerbation of IPF bilateral, ground glass obesities and or consolidation can be present on the background of usual interstitial pneumonia. High resolution CT patterns that not suggestive of usual interstitial pneumonia don't rule out the diagnosis of IPF. Up to 30% of cases with histologic diagnosis of usual interstitial pneumonia may have high resolution CT finding more consistent with alternative diagnosis. Pleural diseases is uncommon in IPF, so its presence should raise the possibility of alternative diagnosis such as rheumatoid arthritis, systemic lupus erythematosus, asbestosis, heart failure, drug-induced lung disease, or lymphangitis carcinomatosis. Nodular pleural abnormalities affecting upper lung zone may be caused by idiopathic pleuropulmonary fibroelastosis. Following initial evaluation, multidisciplinary discussion between clinician and radiologists should guide further diagnostic workup. This is a frame of the diagnostic workup of the IPF from the start. We search about the suspicions of clinical diagnosis of IPF, so the age more than 60 years old, chronic dyspnea on exertion, non-productive cough, bibasilar curriculums, no history or examination or laboratory findings suggestive of environmental or rheumatic diseases. Then we will obtain high resolution CT chest and assess the likelihood of IPF through multidisciplinary discussion. If both clinical features are consistent with IPF and high resolution CT demonstrate probable or definite usual interstitial pneumonia, we can establish the diagnosis of IPF and no need for biopsy. But if the high resolution CT is indeterminate, but the clinical features are less typical, this is possible IPF. The diagnosis of IBF can frequently be made without biopsy on the basis of characteristic presentation in studies onset of dyspnea in patients over age of 60 years old in combination with features of usual interstitial pneumonia or probable usual interstitial pneumonia on high resolution CT chest. Clinical exclusion of other known causes of radiologic usual interstitial pneumonia is necessary, including environmental exposures, medications, and rheumatic disease. And this is a high-resolution CT pattern of confident usual interstitial pneumonia or probable usual interstitial pneumonia or indeterminate or if suggestive alternative diagnosis. In case of confident usual interstitial pneumonia, the distribution is subpleural and basal predominant, often heterogeneous, and the CT features include honeycombing with or without traction bronchiectasis, presence of irregular thickening of interlocular septa, usually superimposed with reticular pattern and mild ground glass opacities. Regarding the probable usual interstitial pneumonia pattern, the distribution subpleural and basal and predominant, often heterogeneous. The TT features include reticular pattern with traction bronchiectasis, may have mild ground glass opacities, and absence of subpleural sparing. Indeterminate for usual interstitial pneumonia pattern, the distribution diffuse without subpleural predominance, and the CT features not suggest any specific etiology. The features suggestive of alternative diagnosis, distribution like pre-bronchovascular predominant with subpleural sparing, like non-specific interstitial pneumonia, perilymphatic distribution like sarcoidosis, upper or mid-lung zone, lung-like hypersensitivity pneumonitis or connective tissue lung diseases and sarcoidosis, subpleural sparing. And the lung finding may include cysts or mosaic attenuation, predominant ground glass, profuse centrilobular micronephrosis, consolidation, or mediastinal finding. This is the main clinical conditions associated with usual interstitial pneumonia, including IBF, rheumatic disease, drug toxicity, chronic hypersensitivity pneumonitis, asbestosis, familial pulmonary fibrosis, Hermansky-Pudlak syndrome, and short Lemire syndrome. When the results of clinical evaluation, laboratory testing, and high-resolution CT don't allow confident diagnosis of IBF after multidisciplinary discussion, lung biopsy should be considered. The decision for biopsy requires assessment of the benefits of having definitive diagnosis relative to the risks of invasive procedure, mortality less than 2%, bleeding, and prolonged air leak, and guidelines suggest that lung biopsy is not necessary in patients with high-resolution CT pattern considered definite or probable for usual interstitial pneumonia when a multidisciplinary discussion yield a confident diagnosis of IBF. For patients with newly diagnosed interstitial lung disease of uncertain etiology, good physiologic reserve, and high-resolution CT pattern is indeterminate for usual interstitial pneumonia or suggestive of alternative diagnosis, the benefits of surgical lung biopsy generally outweighs the risk. However, patients with severe pulmonary physiologic impairment like moderate or severe pulmonary hypertension or supplemental oxygen, patients with substantial cardiovascular comorbidities are at high risk for pulmonary and non-pulmonary complications of the thoracic procedures, irrespective of the underlying diagnosis. Lung biopsy rarely helpful in the setting of active interstitial lung disease exacerbation, rapidly progressive interstitial lung disease, or acute respiratory failure. In such cases, the acute process post decreases the chance of accurate diagnosis of the underlying disease and greatly increase morbidity and mortality of the procedure. The pathologic diagnosis of usual interstitial pneumonia requires a large enough samples to obtain architectural features consistent with the disease. Small sample size or different sampling of honeycombing changes only are the most common reasons for inadequate specimens. Surgical lung biopsy is a traditional approach to tissue biopsy sampling for diagnosis of IBF. The procedure may be performed via VATS or tracheotomy. Ideally, biopsies are obtained from more than one lobe of the lung and from areas of varying severity. The lung biopsy sample should be greater than 4 centimeters in greatest dimension and include depth from pleural surface of 3 to 5 centimeters. Surgical lung biopsy always yield an adequate specimen and a definitive diagnosis in combination with clinical assessment, and high-resolution CT is made in 89% of the patients. Transbronchial cryobiopsy is an acceptable alternative to surgical lung biopsy in centers with experience in this technique. It offers a diagnostic yield of approximately 80% compared with 90% of surgical lung biopsy. Sample number correlate most significantly with the diagnostic yield with 3 or more samples preferred. Rate of pneumothorax approximately 9% compared with 6% prolonged air leak on the surgical lung biopsy, but the procedure is less invasive than the surgical biopsy and can potentially done as an outpatient unlike thrombectomy. The complications of the lung biopsy known prolonged air leak, pneumothorax, but it may be associated also with development of acute exacerbation, and this is the most serious side effect. So diagnosis without biopsy can be determined by clinical and radiological features, as without biopsy as discussed before. Diagnosis with biopsy, the histopathology, the usual interstitial pneumonia is the histopathological pattern associated with the clinical diagnosis of IBF. A usual interstitial pneumonia-like pattern of injury can be seen in other fibrotic lung diseases like rheumatic diseases, hypersensitivity pneumonitis, drug toxicity, and the histologic hallmark and the diagnostic criteria for usual interstitial pneumonia is heterogeneous appearance with alternating areas of normal lung, fibrosis, fibroblastic foci, and honeycombing. The peripheral subpleural parenchyma is the most severely affected. Fibroblastic foci, which are areas of active fibroproliferation characterized by clusters of fibroblasts and myofibroblasts that lie in continuity with established fibrosis, are the hallmark of features of IBF. Features to suggest an alternative diagnosis, including granuloma, prominent airway center changes, inflammation separate from areas of honeycombing, should be absent to diagnose IBF. Differential diagnosis of idiopathic pulmonary fibrosis. The first issue, non-specific interstitial pneumonitis, which is a type of idiopathic interstitial pneumonia, frequently both in the differential diagnosis of IBF. The characteristic features: diffuse ground glass opacities on high-resolution CT chest, a reticular pattern, intraction bronchiectasis, and honeycombing generally absent. The diagnosis generally requires histologic confirmation by lung biopsy. Also, rheumatic disease can be both in the differential diagnosis. Most commonly, rheumatoid arthritis can develop usual interstitial pneumonia-like pattern of lung injury, although non-specific interstitial pneumonia is the most common type of interstitial lung disease among patients with rheumatic diseases. Differentiating rheumatic diseases associated interstitial lung disease from IBF is largely based on identifying clinical features that provide clues to presence of rheumatic disease like arthritis, rheumatoid nodules, renal phenomenon, skin changes, muscle weakness, and abnormal esophageal motility. On high-resolution CT, features suggestive of rheumatic disease may include pericardial effusion or pleural effusion or esophageal abnormalities. Also, drugs and irradiation-induced usual interstitial pneumonia can be both in the differential diagnosis, and it is largely a matter of correlation with clinical information and the treatment associated with usual interstitial pneumonia pattern of pulmonary toxicity, including cyclophosphamide, bleomycin, methotrexate, and nitrofurantoin. Also, asbestosis is associated with occupational exposure like mining asbestos, and the high-resolution CT pattern associated with asbestosis is similar to the IBF, but the pleural plaques, particularly with linear bands of calcification, are clue to the underlying diagnosis. Definitive diagnosis of asbestosis require appropriate occupational history and administration of asbestos fibers and tissue specimen. Chronic hypersensitivity pneumonitis can present with usual interstitial pneumonia pattern on imaging or histopathology. The typical appearance includes central lobular nodules and lobular areas of degrees of perfusion on high-resolution CT, although these features are not always present. The histopathological finding of poorly formed granulomas or joint cell in the interstitium, even if rare, should raise suspicious for chronic hypersensitivity pneumonitis. This is pictures of high-resolution CT pattern of chronic hypersensitivity pneumonitis. Pulmonary Langerhans histiocytosis, also referred as pulmonary eosinophilic pneumonia or pulmonary histiocytosis X, disease of a smoker in young age from 20 to 40 years old with characteristic high-resolution CT pattern. including mid to upper zone predominance, multiple cysts, nodules, and interstitial thickening. While lung biopsy not always needed for the diagnosis, the histopathology typically shows cysts and aggregates of Langerhans like dendritic cells identified by CD4 207 S100 CD1A positivity immunostaining. Aerospace enlargement with fibrosis seen in cigarette smoker that can mimic honeycombing cyst on high resolution CT, but it tend to predominate in the upper to mid lung zones, pairing the most peripheral parts of the lung and characterized by thinner walls than typical honeycombing cyst. Combined pulmonary fibrosis and emphysema seen in male smokers characterized by dyspnea, upper lobe emphysema, lower lobe fibrosis, and abnormalities of gas exchange. Pleuropulmonary fibroelastosis can be idiopathic or chemotherapeutic drug-induced, is a rare process that's characterized by upper lobe pleural and subpleural parenchymal fibrosis, and the pattern of pleural thickening and upper lobe predominance should raise suspicious for this condition. Now we have to talk about the treatment of idiopathic pulmonary fibrosis, and it includes supportive care, medicine, and lung transplantation. The most important components of supportive care for patients with IPF are provision of supplemental oxygen when needed, education, pulmonary rehabilitation, vaccination against streptococcus pneumonia and influenza. Virtually all patients with IPF will require supplemental oxygen initially just with exhaustion and then continuously. Oxygen therapy should be prescribed to enable maintenance of normal activity and possibly to prevent or delay the onset of secondary pulmonary hypertension in hypoxemic patients. Education for patients with progressive IPF, part of education should include discussion of end-of-life issues and advanced directives. Understanding the patient individual preference, beliefs, values is a key step toward appropriate management. Several studies supported the use of pulmonary rehabilitation in interstitial lung disease. A series of 113 patients with interstitial lung disease showed significant reduction in dyspnea and improved in 6-minute walk distance were found for the group participating in the pulmonary rehabilitation program. An important issue also to prevent the pulmonary infections because they are poorly related in patients with IPF. In addition to the acute effect on the lung function, the pulmonary infection may result in acute exacerbation of IPF, which we define as an acute clinically respiratory deterioration characterized by evidence of new widespread alveolar abnormality. We have to vaccine all the patients of IPF against streptococcus pneumonia, influenza, Bordetella pertussis, and COVID-19. According to for COVID-19, there has been reports of acute exacerbation of IPF following COVID-19 mRNA vaccination. However, both case reports and clinical experience inform us that the infection with COVID has a larger risk for respiratory failure than vaccination in patients with IPF. So until further data become available, it is recommended to give the vaccination against the COVID-19 for patients with IPF. Early outpatient treatment of respiratory infection, including antibiotic or antiviral, very important to avoid the deterioration of the condition and acute exacerbation. Patients with IPF should be screened clinically for oropharyngeal dysphagia with low threshold for formal evaluation, speech therapy to improve swallow function, pharmacological treatment of reflux is reasonable in patients with symptomatic gastroesophageal reflux, with consideration of surgical options in patients with severe disease. It is not recommended to give empiric treatment for reflux in asymptomatic patients. Elective procedures should be performed under local and regional anesthesia with spontaneous ventilation rather than with mechanical ventilation when possible. As use of non-invasive ventilation via face mask, nasal device, or laryngeal mask airway is not protective against lung injury and may worsen the aspiration risk. Several pharmacological interventions have been found to be harmful to patients with IPF in large clinical trials. These include combinations of prednisolone, azathioprine, and acetylcysteine, warfarin in patients without additional indication for anticoagulation, and ambrisentan, We should avoid poorly immunosuppressive therapy unless the patient has a strong alternative indication. Palliative care aims to relieve the suffering of the patient at all stages of the diseases and not limited to end of life of care. Palliative measures including opioids and anxiolytic facial cooling with fan may be helpful for patients with refractory dyspnea or cough, and patients with advanced IBF may benefit from hospice care. Regarding the medical therapy, no medication until now known to cure the IBF, but two antifibrotic medications, nintedanib and pirfenidone, appear to slow the progression of the disease and reduce frequency of exacerbation. In addition, these agents appear to have a mortality benefit. For patients with mild or moderate IBF based on pulmonary function who don't have underlying disease, it is recommended to initiate therapy with either nintedanib or pirfenidone. Current data are insufficient to direct a therapy choice between pirfenidone and nintedanib, and the choice sometimes must be made based on availability. When there is a choice of agent, patient preference and tolerance should be considered, particularly regarding potential adverse effects such as diarrhea with nintedanib versus nausea and rash with pirfenidone. In addition, for patients with more advanced IBF, FVC less than 50% predicted and or DLCO less than 35% predicted, it is suggested to use one of these two agents. The decision is less clear as these patients were excluded from major clinical trials, but observational studies suggest that both agents slow progression of the disease in patients with more advanced disease to a similar extent that's seen in treated patients with less advanced disease. Patients with severe pulmonary hypertension, echocardiographic systolic pulmonary artery pressure equal or more than 60 mm mercury due to advanced IBF should be referred to a specialized pulmonary hypertension center for use of inhaled treprostinil may be beneficial in this population. Other advanced therapies for pulmonary arterial hypertension like systemic prostanoids, sildenafil may be helpful in select patients with IBF, although trials of oral pulmonary vasodilators have not demonstrated benefit in clinical trials. Use of systemic pulmonary vasodilator risks worsening ventilation perfusion matching and increasing hypoxemia and should be performed with caution in advanced centers. Nintedanib is a receptor blocker for multiple tyrosine kinase that mediate elaboration of fibrogenic growth factors like platelet-derived growth factor. The standard dose of nintedanib is 150 mg twice daily, 12 hours apart. Liver function should be assessed prior to initiation of nintedanib, and patients with moderate or severe hepatic impairment shouldn't take nintedanib. After initiation, liver function tests should be repeated monthly for 3 months, and then every 3 months thereafter, and as clinically indicated, dose modification or interruption may be necessary for liver enzyme elevation. Pregnancy tests should be performed prior to initiation of therapy in women of childbearing age, and conception avoided until the last 3 months after the last dose. Clinical trial, the main benefit of nintedanib is a reduction in the rate of decline in the lung function and a longer time to the first exacerbation. Pirfenidone is an anti-fibrotic agent that inhibits transforming growth factor beta, stimulated collagen synthesis, so decrease extracellular matrix and block fibroblast proliferation in vitro. The dose of pirfenidone range up to 40 mg per kilogram per day. The 3 divided doses should be initiated at a dose of 267 mg 3 times a day. After 1 week, increase to 534 mg 3 times a week. And after the second week, we give the full dose 801 mg 3 times a week, 3 times a day, and it should be taken with food. The pirfenidone slowed the progression of lung impairment in patients with pulmonary fibrosis due to Hermann-Steinböck syndrome in addition to IBF. As regards the lung transplantation, IBF is the most common interstitial lung disease among referrals for lung transplantation, and the second most frequent disease for which lung transplantation is performed. The median survival following lung transplantation for IBF is estimated to be 5.2 years. Patients with IBF have the highest death rate among the diagnostic group on transplant waiting list. For this reason, early referral for transplant evaluation should be considered even before the response to initial therapy has been determined. General guidelines for timing of the failure for transplantation include histologic or radiologic evidence of usual interstitial pneumonia in the following: DLCO less than 40% of predicted, FEVC less than 80% of predicted, dyspnea or functional limitation attributable to lung disease, decrease in pulse oximetry below 98%, even if only during exertion. Criteria for placing on transplant list include the following: decline in FEVC equal or more than 10% during 6-minute walk test, decline in DLCO equal or more than 50% during 6 months of follow-up. On 6-minute walk test, oxygen desaturation less than 88% or distant walk less than 250 meters or more than 50-meter decline in the distant walk or over 6 months. Pulmonary hypertension or right heart catheterization or transthoracic echocardiogram. Finally, hospitalization because of respiratory failure, pneumothorax, or acute exacerbation. Although single lung transplantation has been a standard procedure for IBF, bilateral lung transplant may prove to be having a long survival. Mild to moderate secondary pulmonary hypertension preoperatively increased the risk of reperfusion injury in one study, but didn't appear to affect survival in 2 retrospective studies. Following single lung transplantation, the low lung compliance and high vascular resistance of the remaining native lung preferentially direct ventilation and perfusion to the transplanted lung. Cystis, poly, and bronchitis that occasionally develop in the later stages of IBF can act as a needles for infection. In this situation, bilateral lung transplantation would be preferred. Future directions: combination of nintedanib plus pirfenidone together to slow but not halt the progression of IBF. Phosphodiesterase 4B inhibitor, which prevent the degradation of cyclic adenosine monocyclate, adenosine monophosphate, which has antifibrotic and immunomodulatory effects. Ventraxine or serum amyloid A inhibit monocyte differentiation into pro-fibrotic fibrocyte or pro-inflammatory macrophages.
Assalamu alaikum, Dr. Rashid. We finish usually at 9 o'clock, and now it is 9:10. How many minutes left?
Maybe less than 5 minutes.
If you like to review the management again tomorrow, we can arrange another time.
No,
If you can finish today,
no.
No problem.
Less than 5 minutes, okay?
No problem.
I will talk shortly about IBF exacerbation because it is an important issue about IBF. The following feature proposed to define IBF exacerbation: a non-diagnosis of IBF, acute worsening typically less than 1 month, CT of the test with new bilateral ground glass opacification and or consolidation superimposed on a background of finding consistent with usual interstitial pneumonia. Heart failure or fluid overload does not fully explain the worsening. Risk factors for acute exacerbation, including respiratory infections, aspiration, mechanical ventilation, and immunosuppressive therapy. Diagnostic evaluation should include first laboratory test. We should do complete blood count and differential cell count, BNB, serial troponin, procalcitonin, and sensitivity dimer. For potential lung infection, we perform blood cultures, urinary antigen assay for strep pneumonia and Legionella, rapid influenza antigen test for respiratory infection, and PCR for respiratory viruses and COVID. We should have high-resolution CT chest to detect the consolidation or the new ground glass, and we should have low threshold for obtaining CT pulmonary angiogram to rule out pulmonary embolism. Also, we can do bronchoscopy and then to detect the infections, but we should avoid the transbronchial biopsy or open biopsy. When treating the IBF exacerbation, we have to start with supportive measures. Initial management of exacerbation include supplemental oxygen, ampulation of shortness of breath. All guidelines now advise against the use of mechanical ventilation because of the very poor prognosis. Glucocorticoid, we can suggest a trial of empiric glucocorticoids, starting dose of prednisolone 1 milligram per kilogram per day orally to methyl prednisolone 1 gram per day for 3 days, followed by prednisolone taper based on the severity of the disease and response to therapy. There are no data for examining the role of nintedanib or pirfenidone, but they said we can continue this medicine if already started, but not initiate de novo therapy during the acute exacerbation. Lung transplantation is occasionally possible in patients who have previously undergone transplant evaluation, but it carries significant risk and usually not feasible in midst of acute exacerbation. Palliative care طبعا, given the poor prognosis of patients with acute exacerbation of IPF, the palliative care consultation to provide relief for symptoms and stress for the patient and family is protected. So we routinely use palliative care services and extra layer of psychological support of this patient. The prognosis of IPF exacerbation is very bad. Approximately 40% of the IPF deaths and more prognosis, and the median survival following acute exacerbation is approximately 3 to 4 months. Now I finish my lecture. Thank you. I finished my lecture course. Anyone have any questions?
Thank you, Dr. Rasha. There is one question asking about safety of ibuprofen in asthmatic patients.
Okay. The ibuprofen or non-steroidal anti-inflammatory drugs for some patients exacerbate the asthma and the other patients not exacerbating the asthma, because the pathogenesis of asthma is different. Some